हेलो मेरे प्यारे प्यारे बच्चों, dear loving students, how are you all? Today we are starting MIST 25 most important YouTube live question discussion session series, and our first session is the Obstetric session. Without any delay, we are starting the session because my goal in these 3 hours is to cover almost whole obstetric, all the important areas, all the important questions. I will try my level best to deliver the whole obstetric in 3 hours. ये मेरा वादा है बेटा, 3 घंटे में obstetric के हर कोने को हम छू के आएंगे, और हमारी कोशिश यही होगी कि आज के इस 3 घंटे के सेशन से हमारे 12 जनवरी 2025 के FMG एग्जाम के, अगर भगवान ने चाहा, सारे क्वेश्चन सॉल्व हो जाएं. If Almighty is kind enough, we will be able to solve almost all the questions of obstetric. And we are together in this journey. हम इस जर्नी में बेटा साथ हैं. 12 जनवरी तक 4:30 बजे तक हम साथ हैं, और शाम के 4:30 बजे तक अपनी शिद्दत से, पूरी मेहनत से मैं पूरी कोशिश करूंगा जिससे आपके सारे obstetric के क्वेश्चन ठीक हों, क्योंकि मुझे 12 जनवरी को शाम 5 बजे आपसे ताली बजवानी है ना? So let's begin our YouTube live session of obstetric. We are starting with this session with this motivational pic of recently passed students who cleared our FMG exam with flying color. And he is your loving Vinny sir, and you can see people say he is god of surgery. I know very well. Because I know him since beginning, so I know that he is really the god of surgery. And you can see these pics are enough to motivate you. All of them cleared this FMG exam with flying color. Beta, you should see yourself among them. हमें अपने आप को इन बच्चों में देखने की कोशिश करनी चाहिए, विजुअलाइज करना चाहिए कि हम भी ऐसे ही पास होंगे, and one day we will go to Delhi to collect our certificate at NB, and then we will go to MIST. We will be here with this kind of pic. थोड़ा सा सेलिब्रेट करेंगे, थोड़ी सी चॉकलेट पार्टी करेंगे, थोड़ी सी फोटो खिंचवाएंगे. एक टीचर के लिए इससे ज्यादा खुशी का मौका और क्या हो सकता है कि उसके बच्चे पास हो गए. चलो बेटा शुरू करते हैं. Another pic just to motivate you that all of these passed the FMG exam with flying colors. Recently passed student. We are starting with question number 1. This is just a pic of our MIST Obstetric workbook. Of course, the last session workbook. Question number 1. Postpartum hemorrhage may be caused by all of the following except. What is the answer? This chocolate is waiting for you. Anyone whosoever gives the correct answer can come after passing the exam and collect the chocolate. You can tell me, sir, I was the one who gave the answer. This is YouTube live chocolate. Fine. What is the answer to this question? Postpartum hemorrhage may be caused by all of the following except. Let me see. D. Wonderful. Wonderful. Rachit, Pooja, Bhigu, Sachin, Anil, Shweta, Rahul, Madiko, Rohit. Wonderful. Ankita, Neha, Madhu, Jay. Wow. See the energy. See the energy. Wow. Let us discuss the question why the answer is D. Accessory placental lobes will cause postpartum hemorrhage. Why? Let us see in this pic. This is the accessory placental lobe. How an accessory placental lobe may cause PPH? This is the main lobe, this is accessory lobe, and this mid area is red, means both the lobes are connected by blood vessels. So this is the subcentriate lobe. After delivery of baby, when fetus is delivered out, placenta is expelled out after delivery of fetus. If by chance some placental lobe is retained inside, uterus will not contract adequately. If placenta is expelled out, uterus will contract adequately, and blood vessels which are running in the middle layer of myometrium, which form living ligature of uterus, they will close. This is called establishment of living ligature of uterus or autoligation. If some placental lobe is retained inside, these blood vessels will not close because uterus will not contract adequately. And if blood vessels remain open, it will lead to postpartum hemorrhage. So this is how accessory lobe leads to PPH. What is the difference between subcenturate lobe and placenta spuria? Placenta spuria, there is no vascular connection between the two lobes. Another one is placenta bilobata, two equal sized lobes. Multilobata if more than two lobes. The complication of accessory lobe, the most common is PPH. Another one, sometimes they may lead to infection because some lobe is retained inside. So this is how accessory placental lobes will cause PPH. How a morbidly adhered placenta will cause EPH. Morbidly adhered placenta is of three types. Let's understand morbidly adhered placenta, then we will understand how it causes PPH. Grade 1 is called placenta accreta, grade 2 is increta, grade 3 is percreta. This is normal, means there is some space between placenta and uterine wall because Nitabuc membrane is present here, fibrin material layer. What is placenta accreta if placenta is attached to myometrium? What is increta if placenta invades myometrium? What is percreta if placenta moves out of serosa? So how these accreta, increta and percreta may cause PPH because they are tightly attached to uterine wall. So after delivery of baby, this placenta does not, suppose this is, my hand is uterine wall and this is placenta. After delivery of baby, since this placenta is morbidly or tightly attached to uterine wall, it will not separate from uterine wall, so it will remain inside. If placenta remains inside, uterus will not contract adequately, blood vessels will remain open, and it will result in PPH. So morbidly adhered placenta also causes PPH. How come macrosomia cause PPH? Macrosomia means fetal weight more than 4 kg. Not only macrosomia, a big baby. If it is a case of multifetal pregnancy or polyhydramnios, so polyhydramnios, multifetal pregnancy and macrosomia, they result in overstretching of uterus. And if uterus remain overstretched for a longer time, beta, we have discussed in the classes with example, if you stretch a rubber band, and if it is stretched for maybe 5 days or 7 days, and then you release it, it does not regain its original tensile strength. Same thing happens with this uterus. It remains overstretched maybe for days or months, so it loses its tone. So how come it will contract adequately after delivery of baby? So this is how it will cause PPH. Oligohydramnios amniotic fluid is decreased inside, so it will not cause PPH. Most common complication of oligohydramnios, our PYQ, is pulmonary hypoplasia. Because amniotic fluid is less, fetus is tightly compressed by uterine wall. So oligohydramnios may result in pulmonary hypoplasia. This is a pic. I just took the photo of our MIST Obstetric workbook. And here it is clearly written what are the causes of uterine atony. Polyhydramnios, multifetal pregnancy and macrosomia, they lead to overstretching. Anemia and grand multipara, the uterine tone is less. If it is a case of prolonged labor or a precipitate labor, very quick labor, all stages of labor are completed in 3 hours. So uterus is overexhausted. If there is uterine fibroid, your surface area increases. If you have used injection oxytocin before onset of labor, which is called injudicious use of oxytocin. Epidural anesthesia for painless delivery. All anesthetics are muscle relaxant. If there is previous history of PPH or after shoulder dystocia drill, so all these may cause uterine atony and may cause PPH. Most common cause of postpartum hemorrhage is uterine atony, and most common type of PPH is primary PPH, which happens within 24 hours. Fine. Let's move. Before moving ahead, just a small advice from my side. Do 15 to 20 minutes walking daily. Smile or laugh. at something. Movement is energy, beta. We are all stuck in our rooms. We are revising at our home. We are there at our home. So what you do inside your room, do some still jogging. Do some still jogging. Movement creates energy. This is the best way. Go for some 10 minutes, 15 minutes, brisk walk in the evening. That will create some momentum. This momentum will keep us lively, will keep us fresh for another revision, maybe session, maybe for 2 hours or 3 hours. So do it. He's your loving Vinny, sir. Again, a celebration movement, you know. We all are waiting for all of you. Once you pass the exam, then you will come here and we will have this chocolate party. You should see yourself in him. See yourself in him. And just visualize that you will be here just after a few months. अपने आप को इस बच्चे में देखो बेटा, इस बच्चे की शक्ल में अपनी शक्ल देखो. हर चीज को स्पोर्टिंगली लेना चाहिए. Visualize that you are here, you are here. मजा करेंगे. We all are waiting for you. Again, just I have included these pics just to motivate you that many students pass the exam. Many FMG students pass the exam. इसीलिए बोलता हूं ना, इतने सारे thousands of FMG students we have the pics. और मुझे वो बात याद आ जाती है बार बार. जलने वाले जलते हैं, जलना उनका काम है. जलने वाले जलते हैं, जलना उनका काम है. जला जला कर राख कर देंगे, FMG हमारा नाम है. इन सारे बच्चों के दिल से एक ही दुआ निकली है, जला जला कर राख कर देंगे, FMG हमारा नाम है. ये सब FMG बच्चे हैं, जला जला कर राख कर देंगे. और जिस दिन नेक्स्ट एग्जाम हो गया, if by chance next exam starts, my dream is all India rank 1 should be a FMG and not a IMG. Without wasting the time, let's discuss this MIST next telegram question. Chocolate question. Let me see who will give the answer. This is lollipop chocolate. जो ठीक से आंसर नहीं करेगा उसकी पिटाई होगी. So now this time I have got this Hanumanji lollipop chocolate also. This is filled with lollipop. So what is the answer to this question? Most common complication of oligohydramnios. MIST next telegram question. Let's discuss it. What is the answer to this question? Very good. Most common complication of oligohydramnios, pulmonary hyperplasia. Ajay, wonderful. Very good, very good. Ankita, fine. Neha, good, wonderful, fine. Next question. Differentiation between maternal and fetal blood may be done by. Differentiation between maternal and fetal blood may be done by. So all these chocolate questions. Pitai for wrong answer, reward or award for correct answer. Very good. Singer's alkali denaturation test. So differentiation between maternal and fetal blood may be done by Singer's alkali denaturation test. The other name is AP test. What is the reagent used here? Reagent used here is 10% potassium hydroxide, 10% KOH. And what is the principle of this test? Fetal hemoglobin HbF is resistant to alkali. So if you take the vaginal blood and mix it with 10% KOH, fetal blood is not denatured. Who will answer the question, how do we diagnose vasa previa? Now the next question is, how do we diagnose vasa previa? Diagnosis of vasa previa. How do we diagnose vasa previa? Differentiation between maternal and fetal blood is by Singer's alkali denaturation test. That's perfect. Very good. Rohit Singh is the first one to answer. This chocolate is for Rohit Singh. Rohit Singh, once you pass the exam, you can come to me and collect your chocolate. This is Vasa Previa Color Doppler Ultrasound chocolate for Rohit Singh. Rohit Singh is the first one to answer that Vasa Previa is diagnosed by color Doppler ultrasound, while differentiation between maternal and fetal blood is done by Singer's alkali denaturation test, which is also called AP test. Very, very important MCQs for our exam. Let's move to question number 2. All of the following are complications of polyhydramnios except. Let us see. Let us see how much is the energy, this chocolate, for this question. All of the following are complications of polyhydramnios except. Let me see the energy. Very good. Very good. Very good. Everyone is answering D. Everyone is saying D. So this pulmonary hypoplasia, very important question. It is caused by oligohydramnios. Pulmonary hypoplasia is a complication of oligohydramnios, while polyhydramnios may result in PPH, polyhydramnios, massive amniotic fluid inside, early pressure and more pressure on membranes, membranes rupture early, creates a tractional force due to sudden gush of fluid out, so cord is pulled down, results in cord prolapse. So cord is pulled down and this cord is attached to placenta. It may result in abruptio placentae as well. So preterm labor, cord prolapse, PPH. What are the other complications of polyhydramnios? Massive fluid inside, respiratory discomfort, malpresentation, preterm labor, pre-labor rupture of membranes, postpartum hemorrhage. All this may happen because of polyhydramnios, and I have listed this screenshot from our MIST Obs-Gynae workbook. MIST Obs-Gynae class notes, complications of polyhydramnios, respiratory discomfort, preterm labor, prom, malpresentation, cord prolapse, abruptio placentae, and PPH. And we have understood, we have revised once again in this session. This is just a screenshot from just recent last session, MIST Obs-Gynae class. This is a pic of cord prolapse if membranes rupture. There is gush of fluid out suddenly which creates a tractional force which pulls the cord down. So this is how cord prolapse may occur. And cord is attached to placenta, and you can see this is the uterine wall and this is placenta. This is the peak of abruptio placentae. You will see a blood clot between uterine wall and placenta. Chadwick sign is seen in Miss Next telegram question. Let's discuss this Miss Next telegram question. Important question for our exam. In fact, the NEET PG PYQ 2 years back. Chadwick sign is seen in. The best answer here is vagina. Wonderful. Next question. A 30-year-old lady came with twin pregnancy at 10 weeks of gestation. Right now she is having 10 weeks gestation. She had a 3-year-old female child who was born at term and had 2 first trimester abortion. Her obstetric score. Let me see. Who is the first one to answer? This chocolate is waiting. See, how many term deliveries she had? 1. How many times she got pregnant? She delivered a term once, then abortion 2 times, and now pregnant again. So G is 4. How many times she had term delivery? 1. How many times preterm? Nothing is written here. How many abortions? 2. And how many living children she has? 1. So 4, 1, 0, 1, 2. 4, 1, 0, 2, 1. Let us see. 4, 1, 0, 2, 1. This looks to be the answer. Not G5, not G5. So the correct answer is this one. So she delivered a term once. She is pregnant for the 4th time. No history of preterm labor. She had abortion 2 times, and right now she has 1 living children. So answer is B. Very good. See the proud father. पप्पा के चेहरे पे कितनी खुशी आती है जब बिटिया के पास होने पे मिठाई खाते हैं. और मजा आ गया इस फोटो को देख के. यार देखो, बिटिया के पप्पा ने मुझे मिठाई खिलाई और मैंने बिटिया के पप्पा को मिठाई खिलाई. What a moment. We all are waiting for these proud moments. कितना गर्व होगा. We all will feel proud, no? When our parents will come to NB, they will come to MIST, and we will have some small celebrations like that. So I still remember, he is Kanishka's father. She is Dr. Kanishka. He is Kanishka's father, and she is Kanishka's mother. Another beautiful pic with the recently passed bacha. Nice bacha. Celebrate your revision daily for 2 minutes in the evening. You have to do some celebration. Maybe you can do some dance, maybe just like this, bangla pale, whatever. द्रोणाचार्य के सभी शिष्य, सारे के सारे, लेकिन इतने सारे, उनके तो कौरव भी शिष्य थे और पांडव भी शिष्य थे. कौरवों की भीड़ में अर्जुन बनकर निखरना होगा. और कौरवों की इस भीड़ में हम अर्जुन कैसे बनेंगे जब हमें चिड़िया की आंख दिखाई देगी. चिड़िया की आंख दिखाई देने का मतलब है वी हैव टू डू revision with consistency and perseverance. Every 2 hours, then we are taking a break of 15 to 20 minutes with consistency and perseverance. चिड़िया की आंख की तरह यहाँ पर केवल एक ही वर्ड दिखाई देना चाहिए और वो वर्ड है PASS पास. हम सबको केवल PASS दिखना चाहिए, पास. Without taking much time, let's move to question number 3. Identify the Leopold maneuver shown in the given image. Let us see this image. What is this Leopold maneuver? Is it 1, 2 or 3? What is the answer? Is it 1, 2 or 3? What is your answer? 1, 2 or 3? What is the answer? 3. Wonderful. Everyone is correct. This is Leopold maneuver 3. This is also called pollic grip or first pelvic grip. What is the purpose of this grip? We hold the head and we try to move it. If we can move the head is ballotable. If head does not move, it is non-ballotable. So who will answer this question? If you are able to move the head here, means it is a ballotable head. Head is engaged or not engaged. Ballotable head, you are able to move, engaged or not engaged. If you are able to move it, ballotable. Very good, not engaged. Very good. Shivendra Yadav is the first one to give this answer. Your chocolate is waiting, beta. Shivendra Yadav. Ballotable means head is not engaged. Answer to this question is Leopold 3. Let us see 4 Leopold maneuvers. This is Leopold 1, which is called fundal grip. Let's revise 4 maneuvers. Fundal grip. What is the purpose? This fundal grip is done to check the presentation and lie. If you are able to palpate the buttocks here, the head is down, cephalic presentation. If head is palpable on the fundus, it is podilic or breech presentation. This is Leopold 2, lateral grip or umbilical grip. We place our hands on either side of abdomen. On one side, we will palpate a spine, on other side, limb. So this gives us idea about the position. Where is the spine? Position of the fetus. This is Leopold 3. This was our image question and this is our FMG PYQ 2018. We are holding the head and we are trying to move it. If head moves, it is called ballotable head, means not engaged. If head does not move, means head has gone down, means it is engaged. So ballotable head, not engaged, non-ballotable head, engaged. This is Leopold 4. We place our 2 hands parallel to inguinal ligament and we try to converge our fingers below the fetal head. If we are able to converge the fingers below the head, head is not engaged. If we are not able to converge, means head has gone down, it is engaged. So 3rd and 4th grip gives us idea whether the head is engaged or not. 4th grip is better because it is more comfortable to the patient. One more important point, Leopold 1, 2 and 3, they are checked while facing towards the head end of the lady. While as you can see, Leopold 4 is assessed while facing towards feet of the lady. Miss next telegram question. A 30-year-old lady presents with amenorrhea of 12 weeks. How much is true conceptional age in weeks? Let me see who is giving the answer to this question. 30-year-old lady presents with amenorrhea of 12 weeks. How much is true conceptional age? Oh, very good. True conceptional age. Wonderful. Who is the first one to write? Shraddha. Shraddha is the first one to write. Then Rohit. Then Vanit, Ajay, Atul, Medico, Path. They are all writing 10. So they are all understanding the concept. We all know that true conceptional age is 266 days, while period of amenorrhea is 280 days. Means true conceptional age, it is calculated from day of fertilization, so it is obviously 2 weeks less than period of amenorrhea. So period of amenorrhea is 12 weeks, so obviously true conceptional age is 10 weeks. Wonderful. A lady presents with amenorrhea and positive urine pregnancy test. Her LMP is 18 June 2023. Her cycle frequency was 32 days. What is her expected date of delivery? So we know according to Nigle's formula, we are adding 7 days to 18. So it is 25. We are subtracting 3 months. So June is 6. 6 minus 3, so it is March. Now it is 2024. But this formula is applicable for regular 28-day cycle. So her cycle is prolonged by how many days? 4 days. Regular cycle is 28-day cycle. In the question it is mentioned that her cycle length is 32 days. So how many days would be added here in the EDD? 4 days. So what is the correct answer to this question? 29th March. Everyone is answering C. Wonderful. Because the cycle is prolonged by 4 days, so 4 days would be added in the EDD. By chance, beta, if the question says her cycle length is 25 days, can anyone write the EDD here? This chocolate. Let me see who is the first one. If cycle length is 25 days, if cycle length is 25 days in this question, means cycle is shorter by 3 days. So what would be the EDD? I am waiting for the first one. What would be the EDD? Cycle is shorter by 3 days. Very good. Bhayu, it was written. The best answer would be then 22 March. Wonderful. Because the cycle length is shorter by 3 days, so we will subtract 3 days. Wonderful, beta. I am very happy. Fine. Let's move. Another pic. I feel really very happy to share this pic. The nice student, Kanha, his name is Kanha, the devotee of Lord Krishna. I am also a devotee of Lord Krishna. And when he came to MIST, he came to NB to collect his passing certificate. When he came to MIST, he came with this beautiful portrait. He met me when I offered my hairs to Tirupati Balaji. Then he met me, so he had one pic with me and he had one pic with Vinesh sir. So when he came to MIST, he brought this beautiful portrait. Thank you, Kanha, once again for bringing it here. And he is your loving Vinesh sir, the people say God of surgery, which is really true. Another pic. These pics are to motivate you that what these pics say. ये पिक्चरें चिल्ला चिल्ला कर क्या बोलती हैं ये मालूम है ना? ये पिक्चरें चिल्ला चिल्ला कर बार बार एक ही बात बोलती हैं। जलने वाले जलते हैं, जलना उनका काम है। जला जला कर राख कर देंगे, FMG हमारा नाम है। ये सब FMG बच्चे चिल्ला चिल्ला कर बोल रहे हैं, जला जला कर राख कर देंगे, FMG हमारा नाम है। तो ये पिक्चर्स हमें मोटिवेट करनी चाहिए। You can keep these pics on your study table and you can just incorporate your face here. अपने आप को इन पिक्चरों में देखो बेटा, ये हम हैं। और कुछ ही महीने के बाद हम NB जाएंगे, मिस्ट भी जाएंगे, सर से भी मिलेंगे, फोटो भी खिंचवाएंगे, चॉकलेट भी खाएंगे। चलो जी। विजय के विधान पर तू स्वयं के प्रमाण लेख, हार कर जो रुक गए हैं उन दिलों में प्राण लेख। तू है अलग, तू हो खड़ा, तू चढ़ शिखर कुछ कर नया। इन लाइनों को बेटा याद रखना। तू है अलग, तू कर नया, कुछ कर नया। तू अलग है, तेरी शक्ल सबसे अलग है। तू जलने वाले जलते हैं, जलना उनका काम है। जला जला कर राख कर देंगे, FMG हमारा नाम है। बस इसे याद रखना। Question number 4. All of the following conditions may be associated with fundal height more than period of amenorrhea except. Means fundal height. If you are checking fundal height, it is more than period of amenorrhea. Polyhydramnios, massive amniotic fluid, yes. Transverse lie. If it is a transverse lie, no. Then fundal height will be less than period of amenorrhea because the fetus is placed transversely. Concealed abruptio placentae. There is hematoma inside, so it will increase the fundal height. If it is a case of multifetal pregnancy, again fundal height will be more. So fundal height will be more than period of amenorrhea if she has forgotten dates, wrong dates, if you are assessing the fundal height with a full urinary bladder, if she is having a fibroid uterus, if it is a case of macrosomia, big baby. In which cases fundal height will be less than period of amenorrhea. Instead of polyhydramnios, oligohydramnios. Instead of macrosomia, IUGR. Fetus has died before 20 weeks, called abortion. 20 weeks onwards, intrauterine fetal demise, transverse lie. In hydatidiform mole also, fundal height is more than period of amenorrhea. In fact, I have kept this table also. This MIST Obscini notes, our class notes. These are the conditions in which fundal height is more than period of amenorrhea. Wrong dates, full bladder, multifetal pregnancy, molar pregnancy, polyhydramnios, concealed abruption because of hematoma inside, macrosomia more than 4 kg, fibroid uterus, there is a pelvic tumor. In which conditions fundal height is less than period of amenorrhea? She has forgotten dates, missed abortion, fetus has died much earlier. Instead of oligo here, IUGR instead of macrosomia, macrosomia will increase the height, but IUGR will decrease the height. Transverse lie, fetus is placed transverse or fetus has died 20 weeks onward. That is called intrauterine fetal demise or stillbirth. This is transverse. If fetus is placed like this transverse, how the fundal height will increase? So in transverse, fundal height is less than period of amenorrhea. This is the case of concealed abruptio placentae. This is the retroplacental blood which enters myometrium, reaches up to serosa. So uterus becomes a wine-colored uterus because of collected blood inside. This is called covalier uterus or uteroplacental apoplexy. So in concealed abruption also, fundal height is more than period of amenorrhea. This is the ultrasound image of polyhydramnios. All this is amniotic fluid, black colored, massive amniotic fluid, polyhydramnios. Fundal height will be more. Oligohydramnios, it will be less. Next telegram question discussion. Testosterone is secreted from our PYQ 3 session back. Let me see who will answer this. This question was asked in our exam 3 session back. Testosterone is secreted from. There was a twist in this question in our FMG exam. Testosterone is secreted from Leydig cells, we all know. But there were 2 options with Leydig cell in our FMG exam. Leydig cells under influence of FSH. Let me see. Very good. Very good. Everyone is answering C. We discussed very well in our classes. LH hormone acts on Leydig cells which secrete testosterone. FSH acts on Sertoli cells which secrete Mullerian inhibiting factor and inhibin. I repeat, this question has been asked 2 times in last 1.5 years. Testosterone is secreted from Leydig cells under influence of LH. Which hormone acts on Sertoli cells? FSH. And then Sertoli cells secrete Mullerian inhibiting factor and inhibin. Management for delayed puberty is. Let me see who will answer this question. Management for delayed puberty. Fine. GnRH agonist in which fashion? We know the rule of K. If we have to increase the activity of HPO axis, GnRH agonists are given in pulsatile fashion. If you have to decrease the activity of our scooter, means HPO axis, GnRH agonists are given in which fashion? Continuous. So management of delayed puberty is GnRH agonist in pulsatile fashion. Everyone answers D here. I am very happy. Management for precocious puberty and precocious menarche would be GnRH agonist in continuous fashion. Precocious puberty, secondary sexual characters before 8 years. Precocious menarche, menses before 10 years. So they have started early. You want to decrease the activity, so GnRH agonist in continuous fashion. What is delayed puberty? If secondary sexual characters don't develop even by 13 years. So they are delayed because the normal age range is 8 to 12 years. So they are delayed. You want to increase the activity of our scooter, that is hypothalamo-pituitary ovarian axis. So for that purpose, it will be given in pulsatile fashion in the synchrony of endogenous release of GnRH. Fine. Your Akshay sir, he is a very competent orthopedic surgeon and a very, very, very brilliant, intelligent, what to say for sir, academician. He teaches wonderful orthopedics. She is your Deepa ma'am, your PSM ma'am. You know better than me. So nothing to say. You know everything about her. And see this बच्चा, अपने आप को इस बच्चे में देखने की कोशिश करो. And see all these faces. they cleared the FMG exam with flying color. Flying color. She is your Deepa ma'am here, all the loving faces, your Vinesh sir, Kunal sir, and all these students have passed the exam and once again proved it. जलने वाले जलते हैं, जलना उनका काम है, जला जला कर राख कर देंगे, FMG हमारा नाम है. भर भर के बच्चे पास होते हैं. Next question. All of the following are indications of medical management in ectopic pregnancy except. So what are the indications of medical management of ectopic? Serum beta HCG between 1000 and 5000, size of ectopic mass less than 4 centimeter, presence of cardiac activity in ectopic. We don't want to prefer medical. For medical management, we want that cardiac activity should be absent. Her vitals are stable, then medical management is given. So what is the answer to this question? Presence of cardiac activity, we do not give it. I have listed this medical management, our Obs-Gynae class notes. What are the indications of medical management? Serum beta HCG between 1000 and 5000, size of mass less than 4 centimeter, cardiac activity preferably is absent. And this question has been asked 2 times in NEET PG and FMG, and in both the exams, they gave the amount of HCG 2800 and size of mass was 3.5 centimeter. So 2800 international units per liter means they fall between 1000 and 5000, and size of mass 3.5 means less than 4. Very, very important MCQ zone. 2 times they asked this question in NEET PG and FMG, copy paste question. HCG levels were also same. And our FMG PYQ was 3 sessions back. They asked a single liner once again, and the question was, which of the following is the indication of medical management of ectopic pregnancy? And the correct option written in our FMG exam was size of mass less than 4 centimeter. So a very, very important and potential MCQ zone. Most common cause of secondary dysmenorrhea is. What is the most common cause of? Meanwhile, you can go through these questions, secondary dysmenorrhea, and other one is gold standard diagnostic tool to diagnose uterine cavity disorder. Meanwhile, I am sharing these pics with you again to motivate you. All of them cleared the exam with flying colors, and you can see they all are celebrating their chocolate party here. So we all will have this chocolate celebration here. These pics can really motivate you. जला जला कर राख कर देंगे. FMG हमारा नाम है. चलो. Coming back to question, most common cause of secondary dysmenorrhea. What is the answer to this question? Vikas Manali, very good. Most common cause of secondary dysmenorrhea is endometriosis. Most common cause of primary dysmenorrhea is genetic, idiopathic, due to excessive PGF2 alpha. Drug of choice to treat primary dysmenorrhea is mefenamic acid. Gold standard diagnostic tool to diagnose uterine cavity disorders. What is the answer? Hysteroscopy. Wonderful. Everyone answered correct. So what I will do, I will show you the questions, then I will move to other slides. Meanwhile, you can think the answers, and then we will come to this slide again. So this is how we'll move ahead to save the time. This is your Shilpi ma'am, loving Shilpi ma'am. I still remember on Teachers' Day, we were having the class. I was having the class downstairs. She was having upstairs. So I got a chance to felicitate her on Teachers' Day. Your loving anatomy ma'am. He is your loving radiology sir, Nishit sir. He was also taking the class, and I got a chance to felicitate him on Teachers' Day. This is the Bajigar, the Jadugar of MIST, the magician, your Saha sir, biochemistry sir. You all love him very much. He is a magician, he is Jadugar, and his biochemistry cracks the questions of medicine as well. Next question. All of the following are correct about choriocarcinoma except. How do we diagnose, how do we suspect choriocarcinoma? Irregular bleeding PV, despite of complete evacuation even after 6 months, yes. Lung metastasis, yes, because choriocarcinoma metastasis very fast via hematogenous route. Visualization of chorionic villi, no. Chorionic villi are seen in complete mole, partial mole, and invasive mole. They are not seen in choriocarcinoma or placental site trophoblastic tumor or epithelial or epithelioid trophoblastic tumor. Chorionic villi are seen in benign conditions, complete mole and partial mole, and one more condition which is GTN, invasive mole, but not in choriocarcinoma. So this is the incorrect statement. Management of high-risk choriocarcinoma is Bexure regime. Yes, that's correct statement. Management of low-risk choriocarcinoma is by single-agent drug methotrexate. Low-risk choriocarcinoma if score is 6 or less than 6. High-risk choriocarcinoma if score is 7 or more than 7. Fine. So answer is visualization of chorionic villi. This is the choriocarcinoma, reddish black mass. This is choriocarcinoma. This is hydatidiform mole, complete mole. You can see vesicles here. This is the peak of hydatidiform mole or vesicular mole or mola hydatidosa or complete mole. We got this question in our FMG exam 2 sessions back. 2 sessions means 1 year. And the question was, which hormone is likely to be raised with the given condition? Let me see who will write here. Chocolate question, which hormone is likely to be raised with the given condition? Our FMG PYQ, just very good. Rohit, I am asking the hormone. This was our FMG exam question. Which hormone is likely to be raised with the given condition? What is the answer to this question? SCG. Himanshu Sharma is the first one to answer. Then Tech Bite, Shraddha, Squash, Anil, everyone. Fine. So SCG will be high with the given condition, our FMG PYQ. This is multiple times asked question in our FMG exam. This is the ultrasound image of uterus, multiple times asked PYQ of FMG and NEET PG. What is the name of appearance? The diagnosis is complete mole or H mole. All these are vesicles. This whole uterus is filled with vesicles. So the diagnosis is complete mole. What is the name of appearance? I am interested in that beta. What is the name of this appearance? Snowstorm. Harsh Jain is the first one to answer. This is snowstorm appearance. Wonderful. Now, let me show you the questions, then I will come again. LH surge is due to, and the second question is, androgens are converted to estrogen by. Let us see. This is the lung X-ray, chest, and these are cannonball appearance. They are seen in metastasis in choriocarcinoma. Important image question for our exam. Another important question is, if lungs are involved in choriocarcinoma, what is the stage 3? Another very important question asked related to this is, what is the most common site of metastasis in choriocarcinoma lung? So these 2 lines have been asked multiple times. What is the most common site of metastasis in choriocarcinoma lungs? And if lungs are involved in choriocarcinoma, what is the stage 3? And what is this appearance called? Cannonball appearance. And what is the route of spread of choriocarcinoma? Hematogenous route. I have taken this screenshot from our MIST Obstetric workbook, the last session class notes. How do you suspect choriocarcinoma? It is a reddish black mass, rare but most dangerous. If she is complaining of irregular bleeding per vaginum, despite of complete evacuation even after 6 months, if there are 4 consecutive plateau levels of serum beta HCG or 3 consecutive rising levels, or pathologist has clearly mentioned in the report that this is the case of choriocarcinoma. Fine. Coming back to our questions, LH surge is due to, let me see who is answering first. LH surge is due to our FMG PYQ 4 session back. 4 session means 2 years back. Our FMG PYQ. LH surge is due to which hormone? LH surge is due to, let me see who is going to write it. Who is going to win the estrogen? Ajay Sharma is the first one. Wow, page 9. You even remember on which page we have written in our class notes. Very good, Ajay Sharma. You deserve this chocolate. You are even answering, we have written this on which page of our MIST Obstetric class notes. Wonderful, Ajay. This chocolate belongs to you. I will remember your name. Androgens are converted to estrogen by. Again, our FMG PYQ 4 session back, 2 years back. Androgens are converted to estrogen by. The answer is aromatase. Wonderful. Everyone has written B. Let's move. Again, you are loving Vinesh sir with recently passed student. You are loving Shilpi ma'am, myself with this pyari bitia who cleared the exam. Your Deepa ma'am, myself, and I remember these girls. I remember she is Dhruti and Purnima. Dhruti and Purnima, they were students from live online batch. They felt very happy. So they sent me this pic when they came to MIST, and then they sent me this pic. They enjoyed this moment very much. And they are from live online batch. When I went to Chennai, they all came to meet me in the hotel and helped me out for something related to some religious thing. I'll share it sometime again. Wonderful. So thank you, Dr. Dhuti, and thank you, Dr. Purnima. Pyari bitiyas. God bless them. Next question. A lady presents in your hospital at 32 weeks gestation with complaints of bleeding PV. She gives history of bleeding PV 1 week before and 10 days before. So she is having recurrent bleeding. Perabdominal findings are normal and fundal height correspond with period of amenorrhea. So growth is also fine because fetal growth is corresponding to period of amenorrhea. Her pulse rate is 70 per minute and blood pressure is 110/78, means her vitals are also normal. What is the most appropriate management for the given condition? So what is the diagnosis? This lady is complaining of recurrent bleeding per vaginum. Abdominal findings are normal, means no uterus is fine, no hardness, nothing is appreciated, fetal parts palpable, fundal height corresponding well. So what is the diagnosis? Diagnosis is placenta previa, and everyone has already started answering D. Let us summarize the management of placenta previa. If there is any emergency situation means she is having excessive uncontrolled bleeding per vaginum, which is leading to hemodynamically instability, or fetus is in distress, something mentioned in the question, or fetus has already died, or there are some gross congenital malformation. So in all these conditions, there is no point in waiting. We have to do emergency cesarean. What is the management of placenta previa? Because placenta is covering internal orb. So the gate is closed. So management of placenta previa is cesarean. Whole debate is about the timing of cesarean, when it has to be done. So if there is any emergency situation, emergency cesarean. If there is no emergency, we can continue the pregnancy till 37 weeks because lungs are finally mature at 37. Management is cesarean because the gate is closed. So we will do cesarean at 37 weeks if everything is fine. So we can easily continue. You can see the gestational age here is 32 weeks and everything is fine. Her pulse rate and blood pressure are normal. So we can continue this pregnancy. And what is the name of expectant management regime of placenta previa? McAfee and Johnson regime. So in this question, if something was written like excessive bleeding or some fetal distress or fetus has died or there are some gross congenital malformation or if she is hemodynamically unstable or her BP is falling, emergency is here. Induction of labor is out of question because the gate is closed. So management of placenta previa is only and only cesarean. The whole debate is about timing of cesarean, when it has to be done. Induction of labor is out of question. So McAfee and Johnson resign. Now, let me share the question, then I will share other thing. Miss next telegram question. A 33-year-old lady presents with continuous dribbling of urine through vagina. She is unable to go for micturition on her own. Which of the following is most likely? So continuous dribbling of urine through vagina, unable to go for micturition. So what is the answer to? Very good, very good. Everyone is writing 37 weeks. I am very happy. You are all understanding the concept. So continuous dribbling of urine through vagina, unable to go. Here it is written, unable to go for micturition. So the answer is vesicovaginal fistula. In this question, if she is able to go for micturition, answer is uretrovaginal fistula. If the question says she is complaining of dribbling of urine through vagina only during micturition, answer is urethrovaginal fistula. We understood very well conceptually in our classes. So here this is the answer. A 32-year-old lady presents with hematuria during menstruation. not otherwise, not throughout the month. We know there are two causes of hematuria during menstruation, which is also called menouria or mensuria. One is there is a fistula between uterus and bladder, uterovesical fistula or vesicouterine fistula, and the second cause is endometriosis of urinary bladder. So in this question, let us see. This is vesicouterine or uterovesical fistula. This is called mensuria. Mens is in urine. Mensuria. So connection. And what is the most common cause of vesicouterine fistula? Most common cause of this fistula is most common surgery performed on uterus. And which surgery is most commonly performed on uterus? Cesarean section. So what is the most common cause of this fistula? Cesarean section. I have summarized the management of placenta previa. Again, a pic from our MIST Obstetric class note. If she is hemodynamically unstable, her BP is falling, excessive uncontrolled bleeding, fetal distress, fetal death, gross congenital malformation, what is the management? Emergency CS. If she is stable, if she is 37 or more, do CS now. If gestational age is less than 37 and no excessive bleeding, no fetal distress, no fetal death, no gross malformation, continue pregnancy till 37 weeks. And how do we continue pregnancy till 37? By expectant management. Name of this regime is McAfee and Johnson regime. So we advise her bed rest, blood grouping and matching. We give steroids for lung maturation. Because this blood inside will irritate amnion, and then amnion will release PGE2 prostaglandin. So there is a fear of initiation of preterm labor in cases of placenta previa or abruptio placentae due to that blood. So if uterine contractions have started, we will give tocolytics, which are the drugs to arrest uterine contraction. And we all know what is the drug of choice as tocolytic nifedipine. Anti-D if she is Rh negative, magnesium sulfate if gestational age is less than 32 to prevent cerebral palsy for neuroprotection. We are doing fetal monitoring by non-stress test, biophysical profile scoring, and serial ultrasound. Fine. Next question. Before this, again, you can incorporate your picture in this pyari bitia. She passed this FMG exam recently, then she came to MIST. These pics can motivate you. Fine. Here's your lovely Nishish sir. We got a chance. He was also taking the class. So all of them passed the exam with flying colors. And I repeatedly tell in my classes that neurons which are wired together, they are fired together. So whatever we are studying or reading in our notes, in our workbook, we should try to imprint them in our brain also. And the best way to do it, when we are revising, revise with the open workbook, maybe for 1.5 hours. But for 20 minutes or 15 minutes, close the workbook or close your eyes and then try to recall the thing which you just revised 2 hours back. So let us see whether we retained it, whether we absorbed it, because only our brain is allowed in examination hall. These notes are not allowed inside the examination hall. If you are stuck at a question there, whom will you ask? किससे पूछोगे यार अगर किसी क्वेश्चन पे अटक गए तो? इसलिए जिस भी चीज को याद किया है केवल नोट्स को खोल के याद मत करो, उसको नोट्स को बंद करके देखो क्या मेरे दिमाग ने इसको चिपका लिया या नहीं. न्यूरॉन्स की वायरिंग करनी पड़ेगी, तभी वो एग्जाम हॉल में फायरिंग करेंगे. नेक्स्ट क्वेश्चन. A lady presents in your clinic at 16 weeks pregnancy with complaint of bleeding PV. She gives history of passing some PCOS as well. Her abdominal examination revealed that fundal height is less than period of amenorrhea. PV findings reveal open internal loss. What is the most likely diagnosis? So she is presenting at 16 weeks. She is saying, Dr. Sahab, I am passing some PCOS also. Fundal height is less, means she has expelled something. What is the diagnosis? Let me ask, what is the diagnosis, beta? Very good. Everyone is answering, this is the case of incomplete abortion because she has expelled the PCOS. This is why fundal height is less and internal loss is open. Why it is not ectopic pregnancy? In ectopic pregnancy, the predominant symptom is pain, while in abortion, predominant symptom is bleeding. Nowhere in the question it is written there is a pain. And moreover, ectopic pregnancies usually don't continue till 16 weeks if they are tubal ectopic. And most common ectopic is tubal ectopic. Clear? And why she will say that she is passing some pieces? So how do you crack these questions if in the question it is written fundal height is equal to period of amenorrhea, internal os is closed, threatened abortion. Fundal height less than period of amenorrhea, internal os open, she is having bleeding, inevitable abortion. Fundal height less than period of amenorrhea, internal os open, she is having bleeding, but at the same time, if this word is written, डॉक्टर साहब टुकड़े जा रहे हैं, अगर कोई लेडी बोलती है डॉक्टर साहब टुकड़े भी जा रहे हैं, if there is history of expulsion of pieces, means products of conception, and some pieces are retained inside, this is incomplete abortion. Why it is not inevitable? Because pieces are written here. Why it is not placenta previa? First of all, we start using the word placenta previa 28 weeks onward. Moreover, why she will pass the pieces? Why fundal height will be less than period of amenorrhea in placenta previa? This is the ultrasound image of incomplete abortion. This is the endometrium beta. This is endometrium in ultrasound. And you can see these are all retained products of conception. So they are all retained inside this endometrium. They are pieces, and she is passing these pieces. But some pieces are still retained inside. This is why this is incomplete abortion. We got a MCQ in our FMG exam 4 sessions back. This image was given. So this is just to tell that how ectopic may be asked in our exam. And there was an arrow pointing here. And examiner asked, which of the following is most common site of ectopic? This is our FMG exam PYQ, and the arrow was pointing towards ampulla. So they asked it as an image question. We all know most common site of ectopic is ampulla, and earliest site of ectopic rupture in tube is isthmus. Last site of tubal rupture is interstitium. ये पिक्चरें आपको मोटिवेट करने के लिए काफी हैं. मिस नेक्स्ट टेलीग्राम क्वेश्चन डिस्कशन. Which of the following is management for decubitus ulcers in uterine prolapse? Let me read the second question also. Meanwhile, you can think it. Which of the following is temporary management for uterine prolapse? Both these questions are our recent FMG PYQ. And very important. They are repeated multiple times. Very important question. Recent FMG PYQ. There is fair chance they may be repeated now. Which of the following is management for decubitus ulcers in uterine prolapse? What is the answer to this question, beta? Let me check. What is the answer? Answer is packing. Answer to this question is packing. Now, next question is, which of the following is temporary management for uterine prolapse? What is the answer for this question? Temporary management for uterine prolapse. Let me see who will answer. Temporary management is ring pessary. Temporary management is ring pessary. Wonderful. Again, this Pari Bitia, she came. All these passed the exam with flying colors. Chalo. All of the following statements are correct about medical termination of pregnancy except, about MTP except. Keeping the records of last 5 years is mandatory. Yes, it is mandatory. We have to keep the records of last 5 years. This is correct statement. Consent of guardian is required in case of minor. Correct statement. There is no age limit for MTP with gross congenital malformation on recommendation of a state medical board. Yes, it is a correct statement. MTP may be done up to 24 weeks in pregnancy due to contraceptive failure. This is incorrect statement. We all know better that MTP may be done only up to 20 weeks. If it is due to contraceptive failure, MTP may be done only up to 20 weeks. So this is an incorrect statement. All these 4 statements are very important lines for our FMG exam for 12th January. Very, very important statement. They are very important lines for our exam. What is this? We all know this is Carmen cannula. Important image question for our exam. This is Carmen cannula. It is a plastic cannula with two openings here. It is used for suction evacuation. And how much is the pressure in suction evacuation? It is 600 millimeter of mercury. And we know diameter of cannula in millimeter correspond to gestational age in weeks, which again correspond to number of cannula. These are important areas related to Carmen's cannula. Let me read out the questions, then we will come back. A 19-year-old girl presents with primary amenorrhea. Very important question. Secondary sexual characteristics are normally visualized in her. What is the next step? Coming back in 30 seconds. A 18-year-old girl presents with complaints of primary amenorrhea. Breasts are normally visualized in her. Ultrasound was done which showed absence of uterus, cervix, vagina. सोचो आते हैं जल्दी से. This is important pick. Suction evacuation. Suction pressure very important, 600 millimeter of mercury. Best method to do MTP in first trimester suction evacuation. Suction evacuation may be done up to 15 weeks gestation. Most common method of MTP in first trimester is medical abortion. This is menstrual regulation syringe. How do we diagnose menstrual regulation syringe? How do we identify it as one valve? How do we identify that this is a manual vacuum aspiration syringe? In manual vacuum aspiration syringe, there are two pinch valves. 1, 2. Two pinch valves in MVA syringe, one valve in MR. Important image questions for our exam. Carmen cannula, super duper important. Coming back to Miss Next Telegram question discussion. Who will answer this question? Chocolate question. A 19-year-old girl presents with primary amenorrhea. Secondary sexual characteristics are normal. What is the next step? Very good, Ritik. I am happy. Mohit, very good. Rohit, good. So, what is very good? Aarti is the first one to answer, and this chocolate is for you, Aarti. Please remind me when you come here that this chocolate belongs to you. So this chocolate is ultrasound chocolate, primary amenorrhea question, breast normal. What is the next step? What is the purpose? If breasts are normal, the possibilities are Mullerian agenesis, testicular feminization syndrome, and cryptomenorrhea. The purpose of ultrasound is to see whether uterus is present or not. If uterus is present, cryptomenorrhia. If uterus is absent, it is Mullerian agenesis or TFL. Our 2019 FMG PYQ, very important conceptual question. 18-year-old girl presents with primary amenorrhea. Breasts are normally visualized. Ultrasound showed absent uterus, cervix, vagina. There are two possibilities, Mullerian agenesis and TFL. But why the answer is Mullerian agenesis, which may be called MRKS syndrome, Mayer-Rokitansky-Kuster-Hodder, MRKS type 1, only Mullerian agenesis. MRKS type 2 is a combo of Mullerian agenesis with renal and skeletal anomaly. So instead of Mullerian agenesis, we get the option Mayer-Rokitansky-Kuster-Hodder syndrome or MRKS syndrome. Because MRKH or Mullerian agenesis is more common than testicular feminization syndrome. This is why this is the answer here. If which line is added in this question, then answer will only be TFL. आंसर केवल टेस्टिकुलर फेमिनाइजेशन सिंड्रोम होगा अगर इस क्वेश्चन में एक लाइन कौन सी ऐड हो जाए. Who will answer this question? Again, an important chocolate question. Here, which line added in the question? Now the answer will be TFS only. Uterus absent TFS also, uterus absent Mullerian agenesis also. Which line if we add in this question, then answer will become TFS only. Very good. Sunir is the first one. This chocolate is for you, Sunir. Sunir, khao tum. Shabash. Very good. This chocolate belongs to Sunir. If one line is added in this question that axillary and pubic hairs are absent, the answer will only be testicular feminization syndrome. Wonderful. I'm very happy. Keep it up. Your loving Vinny sir, again celebration movement, मजा आता है, दिल खुश होता है. And when we meet these loving students, जो चिल्ला चिल्ला के कहते हैं, जला जला के राख कर देंगे, FMG हमारा नाम है. We become a student and they become teachers. And then we learn how did they score 200, how did they score 240, how did they score 170, 180, 190. But some days will be good, some days may not be. If you are not able to accomplish डेली टारगेट, कभी कभी लगता है आज का काम जो सोचा था वो पूरा नहीं हो पाया. आई कुड नॉट अचीव माई टूडेज टारगेट. सिर्फ एक बात याद रखना, माई टुमारो इज बेटर देन माई टुडे, माई इवनिंग इज बेटर देन माई मॉर्निंग. यार नहीं हुआ ना, सुबह को किसी कारण से पूरा टारगेट अचीव नहीं हुआ, आई विल स्प्लैश सम वाटर ऑन माई फेस, थोड़ा सा चेहरे पे पानी लगा लूंगा, थोड़ा सा शॉवर भी ले सकता हूँ, विल हैव सम वॉलनट्स और आलमंड्स, बढ़िया अच्छे से एनर्जी के साथ बैठूंगा और अपनी इवनिंग को अपनी मॉर्निंग से बेटर बनाऊंगा. अपने कल को आई विल मेक टुमारो बेटर देन माई टुडे. व्हाई? बिकॉज आई हैव टू बी हियर जस्ट आफ्टर फ्यू मंथ. क्योंकि मुझे केवल कुछ महीनों के बाद एनबी आना है, एनबी के बाद मिस्ट आना है और अमृतसर से अपनी चॉकलेट लेनी है. और एक बात और यार, कई बार क्या होता है, सम स्टूडेंट्स मिस आउट, मैं भी नहीं मिल पाता, मेरा बड़ा मन करता है. सो व्हेन यू पास द एग्जाम, व्हेन यू आर कमिंग टू एनबी, यू आर कमिंग टू मिस्ट, प्लीज टेक्स्ट मी 1 week बिफोर. यार आई ट्राई माई लेवल बेस्ट to stay in Delhi only during those time. But sometimes I also have to go somewhere. So please text me 1 week before. Sir, I am coming to collect my certificate on this and this date. So I will try my best to be here. और मिलके मुझे चॉकलेट देने में बहुत खुशी होती है बेटा, बड़े दिल से देता हूँ. ठीक है ना? चॉकलेट तो एक बहाना है. आप सब डॉक्टर हो, किसको चॉकलेट चाहिए? थोड़े दिन बाद मैं बूढ़ा हो जाऊंगा, आप मुझे चॉकलेट दोगे. I will grow old after some time. You will give me chocolate. Chocolate is just a token of love. It is just about sharing. How did you score 200? How did you score 210? और फिर थोड़ी सी बात हो जाती है, अच्छा लगता है. और इन्हीं पिक्स का वेट कर रहा अपन. ये देखो, पापा और मम्मी के चेहरे की खुशी देखो. See the smile on parents' face, father's face, mother's face, the proud moment. प्यारा बच्चा, see him. दिस इज हिज अर्निंग. ये कमाई है, असली कमाई. अपने चेहरे पे गर्व, अपने पापा और मम्मी के चेहरे पे ये गर्व. ऐसी फोटो खिंचानी है हमें सबको यहाँ पे. वी ऑल विल बी हियर, वी विल हैव नाइस सेलिब्रेशन. थोड़ा सा जोर और लगा दो बेटा. योर लविंग विनी सर वंस अगेन. Which of the following complications is most likely in the twin pregnancy shown in this image? अब क्वेश्चन ये है कि सबसे पहले तो वी हैव टू आइडेंटिफाई विच टाइप ऑफ ट्विन प्रेगनेंसी इज देयर. लेट अस सी. सुपर डुपर इंपॉर्टेंट अल्ट्रासाउंड इमेज फॉर अवर एग्जाम. व्हाट इज द आंसर? विच टाइप ऑफ ट्विन? आलमंड. हाँ बेटा, अब यार आलमंड कहाँ से कोरियर करूंगा? तुम जल्दी से पास होके आ जाओ, अभी खरीद लो, बाद में आके मुझसे मिल लेना. विच टाइप ऑफ ट्विन प्रेगनेंसी इज दिस? बताओ. मोनोकोरियोनिक और डाइकोरियोनिक? गुड गुड. I'm happy. Therapist, yes. Which type of twin is this? This is monochorionic pregnancy. As you can see, only one placenta, and which sign is formed? This is intertwin membrane or dividing membrane. This is one fetus. This is second fetus. And this is the intertwin membrane or dividing membrane dividing the two fetuses. Only one placenta, so monochorionic. Which sign is formed? T sign. So we identify monochorionic pregnancy with the T sign. Now the question is, which of the following complications is most likely in this pregnancy? Monochorionic. Aneuploidy, they are more common in dizygotic twins because of two zygotes, two types of genetic material. So aneuploidy are more common in dizygotic ones. Cord entanglement, umbilical cord of one fetus entangle with another one. This is possible if both are sitting in one room. This is possible in monoamniotic. Interlocking of twins, this is a different word. If first fetus is breech and second is cephalic, that is called interlocking. So the answer is twin transfusion syndrome. Who will answer this question? Important image question of placenta. What is the answer to this question? Very good. Dichorionic diamniotic. Wonderful. What is this? What is this? Very good, Uttupriya Verma, recipient twin cardiomegaly. Wonderful. This is monochorionic diamniotic because of thin dividing membrane. And you can see the vascular anastomosis, dividing membrane is thin. Here the dividing membrane was thick and there was no vascular anastomosis. So this was dichorionic diamniotic. This is monochorionic diamniotic. Let me share the questions. I will come here again. Miss next telegram question. Which type of dysmenorrhea has cramping pain starting at the onset of menses and more pronounced on the first day of menstruation? Coming back. Spasmodic pain during dysmenorrhea is attributed to. Coming in 20 seconds. Meanwhile, answer this question. Super duper important image question for our exam. Very important. Who will answer this? We saw in the question that was T sign. Monochorionic pregnancy. What is this sign? Very important for our exam. Let me see who is the first one to answer. You can see there are two placenta. So which sign is formed here? This is called which sign? Lambda sign or twin peak sign. So this lambda sign or twin peak sign, it is seen in which pregnancy? Dichorionic pregnancy. While T sign is seen in monochorionic. Very, very, very important text question. Very, very, very important image questions for our exam. T sign, monochorionic, lambda or twin peak sign, dichorionic. Wonderful. Who will answer this? What is the diagnosis here? Very important for our exam. Which type of placenta? Which type of placenta? Let me see which type of placenta this is. Monochorionic, monoamniotic. No dividing membrane here. There is no dividing membrane in one room only. So what is this diagnosis? What's happening here? Umbilical cord of one fetus may entangle with the cord of other one. This is called cord entanglement. So cord entanglement can occur in which twin? Monoamniotic. They are in one amniotic cavity. This is twin transfusion syndrome. This is donor twin and that's the recipient. Who carries the worst prognosis? Recipient. It dies early because of high cardiac output failure. Let me write what was this? This is cord entanglement. This is cord entanglement. This is possible in monochorionic, monoamniotic. And this was twin transfusion syndrome which occur in monochorionic diamniotic. Next question. A pregnant lady went to a dentist for some treatment 1 week back. Now she presents in your nursing home with abdominal pain. Her gestational age is 32 weeks. On examination, uterine contractions are present. Internal os dilatation is 3 centimeters. Cervical length is 2. What other findings may further add in diagnosis of the given condition? So what keywords are mentioned in the question? This is a pregnant lady who went to a dentist. Now she is presenting and the gestational age is 32 weeks. Uterine contractions are present. She went to dentist, so some infection occurred. Infection resulted in inflammation of chorion and amnion, chorioamnionitis. If anything happens to membrane, membrane release prostaglandin, which prostaglandin is released from membrane PGE2, which initiates uterine contraction. So preterm labor begin. What are the diagnostic criteria for preterm labor? The most important is uterine contraction. If it is associated with any one of the following, like cervical length cutoff is 2 centimeter, internal os diameter 3 centimeter, and which shaped membrane? If cervix is dilating, membranes which bulge out. Membranes will bulge out and will create a U shape. So U-shaped. And one more thing, fetal fibronectin, which is a fetal glycoprotein between fetal and maternal surface. Due to uterine contractions, it enters cervicovaginal secretion, and if it is more than 50 nanogram per ml, it is diagnostic of preterm. So answer to this question is nitrazine paper test, red litmus paper will turn blue if amniotic fluid enters vagina, so it diagnoses pre-labor rupture of membrane. Furning pattern again diagnoses pre-labor rupture of membrane. USG oligohydramnios will again diagnose pre-labor rupture of membrane. So U-shaped membranes is the answer. I've taken this MIST Obs-Gynae class notes pick here. This is our last session MIST Obs-Gynae class note. Diagnosis of preterm labor. Most important is uterine contraction. This is the most important to diagnose preterm labor. There should be 4 or more than 4 contraction in 20 minutes or 8 or more in 60 minutes with any one of the following. How much is the cutoff for cervical length? 2 centimeter. Internal os diameter 3 centimeter. Which shape membrane U? And how much is the amount of fetal fibronectin? More than 50 nanogram per ml in cervicovaginal secretion. So this diagnoses preterm. Let me share the questions, then I will come back. Which of the following is definitive diagnosis for endometriosis? This question was asked in our FMG exam 3 sessions back, means 1.5 years back. In our FMG exam, it was investigation of choice. I have written definitive diagnosis here. Second question is, which fibroid can be removed easily during cesarean section? 2018, our FMG PYQ, 2018, December session. I am coming again. These are ultrasound images of cervical shapes with dilatation. If cervix is closed, we do not see any amniotic fluid in cervix, so the shape is T-shaped. Like this. This is T-formed closed cervix. When cervix starts opening, you can see, first of all, the shape becomes Y. With further dilatation of cervix, it becomes V. And we all know this black is amniotic fluid in the cervix. Because cervix is dilating, amniotic fluid is entering cervix. And with further dilatation of cervix, the membranes bulge out. It becomes U-shape, or herniation, or ballooning, or funneling of membrane. So what is the correct sequence of change in shape of cervix with cervical dilatation? T, Y, V, U. Coming back to MIST Next telegram questions again. Which of the following is definitive diagnosis for endometriosis? The best answer here is histopathology. If histopathology is not given in option, what would be the second best answer? Chocolate question to you. If histopath is not given in option, definitive diagnosis for endometriosis. If this is not given here, the answer is laparoscopy. This question was asked in our FMG exam, and the question was, what is the investigation of choice for endometriosis? Laparoscopy. If definitive diagnosis is asked, histopath is not in option, then second best answer would be laparoscopy. Which fibroid can be removed easily during cesarean? December 2018, our FMG PYQ, important question. Subserous, going out, so there is less risk of bleeding. So these subserous fibroids can be taken out easily during cesarean. But a few important advice I want to share. Break time between studies and revisions is very important. You have studied for 2 hours, you have revised for 2 hours. Now you are taking a 15 to 20 minutes break. Just close your eyes. You can do some munching of walnuts or almonds. You will not have a look at your mobile. If by chance it is mandatory, keep the mobile in prone position, not in supine position. Because even if a message pops up, we are distracted towards it because the light flashes on. So keep the mobile in prone position, never in supine position. And try to bring your awareness to your breathing, maybe for 2 or 3 minutes only. Declutter your study table. Make your study table very clean and organized. Try to keep just 1 or 2 workbooks only. See, lovely clean place. So our study table should be clean as display. Read, repeat, revise the same content. We will never read anything new now onward. We will remember Muhammad Ali, who was least afraid of the person who knew 1,000 variety of kick. But he was most afraid of the person who has practiced single kick multiple times. Our notes are our kicks. We will revise them multiple times. Make the best permutation and combination in remaining day. Avoid monotony. Changing subject is the best way. If by chance you feel that you are feeling boring with one subject, change the subject. And the better would be to choose a short subject. You will finish it early, you will gain the confidence. Oh, I finished it up. So your self-esteem will be improved. Next question. A lady delivered a baby 16 hours back. Uterus was not palpable abdominally. She delivered a baby 16 hours back. Uterus was not palpable abdominally. Postpartum hemorrhage had started and oxytocin infusion was given along with uterine massage. So PPH started, oxytocin was given along with uterine massage. Misoprostol has already been given. Carboprost has already been given. Now what is the next step? We know. We have tried these medical management. Oxytocin dose 20 to 40 international units in 550 ml saline or ringer lactate. We use the electrolyte-rich media. Misoprostol 800 micrograms sublingual or 1000 microgram per rectal. Carboprost, the most powerful drug, 15-methyl PGF2 alpha, 250 microgram with intramuscular injection, may be repeated after 15 to 20 minutes, maximum 8 doses mean 2000 microgram. Medical management is tried for 30 minutes time. If there is no response in 30 minutes, we add additional maneuver. The additional maneuver added is uterine tamponade. The most commonly used catheter is Bakri balloon catheter. We put this catheter inside the uterus like this and we inflate the catheter. Maximum 500 ml saline is used to inflate the catheter. It causes the compression of these blood vessels which are running in uterine wall. So this is uterine tamponade. If there is no response, even after uterine tamponade, then we see whether her vitals are stable or not. If vitals are unstable, we can do external aorta compression, which is most commonly done, or we can wrap her in military anti-shock garment or bimanual compression, and then we go for devascularization of vessel. First artery ligated is uterine, followed by utero-ovarian anastomosis, followed by ligation of anterior division of internal ilia. If it doesn't help, subtotal hysterectomy. If it doesn't help, umbrella pack or parachute pack. If after uterine tamponade PPH continued, but vitals were stable, we prefer uterine artery embolization. If it is not possible, then we apply uterine compression sutures, B-Lynch sutures or bridge sutures. So we discuss the complete management of PPH. If the question asked is, according to the latest WHO recommendation, what is the drug which has been added by WHO? Injection tranexamic acid, 1 gram, slow IV in 20 minutes. Very, very important. Let us solve these mismatched telegram questions. All of the following are causes of primary amenorrhea except. Let me see who will answer this. All of the following are causes of primary amenorrhea. MRKH syndrome, primary amenorrhea, yes. Swyer syndrome, primary amenorrhea. Sheehan syndrome, secondary amenorrhea. Androgen insensitivity syndrome, primary amenorrhea. Sheehan syndrome is postpartum necrosis of anterior pituitary. So that is secondary amenorrhea. Fine. Let's move. Again, your Deepa ma'am. See the happy faces. These parents. Parents के चेहरे पे खुशी देख के बेटा मजा आ जाता है. See this बिटिया and parents, father and mother. These pics are enough to motivate you, us. हम सब पास हो जाएंगे बेटा. Next question. A pregnant lady presents in your OPD at 36 weeks. She is presenting at 36 weeks pregnancy and her complaint is abdominal pain. Fetal parts are palpable. superficially. They are palpable superficially. Station and position are not appreciated. Oh my God. Fetal heart rate is 70 per minute. Normal fetal heart rate is 110 to 160. Ultrasound shows a moderate amount of free fluid in peritoneal cavity. She delivered her previous baby by lower segment cesarean section. What is the most appropriate management? So what is the diagnosis, beta? Very good. Neha, Gilson, Bhargav, very good. So the diagnosis here is uterine rupture. Why the diagnosis is uterine rupture? As you can see here, fetal parts are palpable superficially. If uterus has ruptured, fetus comes up superficially because of rupture of uterus. See this image. The uterus has ruptured. If uterus ruptures, fetus comes up superficially. This is why fetal parts are palpable superficially. And first of all, there will be fetal bradycardia. In our question, it is 70 per minute. Finally, fetal death will occur. If uterus ruptures, there was amniotic fluid around fetus, which will come in peritoneal cavity, and there will be blood as well. So this signifies moderate amount of free fluid in peritoneal cavity. So this is very well. And most specific sign, if uterus rupture, means fetus is not even inside uterus, fetus comes out. So what to talk of station and position? The most specific sign of uterine rupture is loss of station and position. So the diagnosis here is rupture. So if uterus has ruptured, what you do? You go for immediate exploratory laparotomy. We will try to repair it. If it is not possible, then we will do total abdominal hysterectomy. MIST Obstetric class notes of last session, uterine rupture. When serosa is also separated, fetal bradycardia, fetal parts are palpable superficially, there is complete loss of station and position, free fluid is seen in peritoneal cavity, which is amniotic fluid and blood. She may complain of bleeding, hematuria, guarding because of free fluid. Clear? So all these signify the diagnosis is rupture, and we have to do immediate exploratory laparotomy and will try to repair uterus. This is the normal scar tissue. This is uterine dehiscence. You can see this is scar dehiscence here because serosa is intact. So what is the difference between uterine dehiscence and rupture? If outermost layer serosa is intact, this is impending rupture, uterine dehiscence. If outermost layer serosa is also separated, then only fetus will come up outside superficially. It is rupture. Now, what is the answer to this question? Anti-Mullerian hormone assessment is best method to test ovarian reserve because it is independent of menstrual cycle. It can be done on any day. And what is the normal value of AMH? Normal AMH is 1 to 3.5 nanogram per ml. Normal anti-Mullerian hormone 1 to 3.5 nanogram per ml. And when we diagnose ovarian failure, if levels are less than 0.5, we can write here ovarian failure is diagnosed if levels are less than 0.5 nanogram per ml. So why it is best? Because you can do it on any day. Otherwise, the second best would be serum FSH, but that is done on day 3 of cycle if more than 40 international units. All of the following are contraindications of HRT except venous thromboembolism, contraindication, coronary artery disease, contraindication, CA breast, contraindication, hot flushes is an indication. So this is the answer. HRT, hormone replacement therapy, is given to treat hot flushes. What are other contraindications? If you are suspecting some endometrial hyperplasia or endometrial cancer, some active liver disease. Again, just to motivate you, few pics. See the father, proud father. See proud parents, proud father and proud mother. Next question. All of the following statements are correct except. Let us read the statements. Fundal height on second day post-delivery is 1 finger breadth below umbilicus. Correct statement. 1 finger is equal to 1 centimeter. In NEET PG, they asked finger breadth. Same question, NEET PG PYQ, first statement. Correct sequence of lochia, our FMG PYQ just 2 sessions back. What is the correct sequence? Rubra serosa alba. Postpartum blue, our FMG PYQ 3 sessions back. And in our FMG exam, they asked the question, a lady developed mild depressive illness on day 5 post-delivery. And within first 10 days of delivery, the term used is postpartum blue. So postpartum blue is mild psychiatric illness within first 10 days of delivery. Our FMG exam had on day 5. Again a correct statement. Puerperal pyrexia, 6 July 2024, last session FMG PYQ. Puerperal pyrexia is rise in temperature more than 100.4 degree Fahrenheit within first 24 hours. This is incorrect. I know all of you are very clear. Very good Ruthupriya, very good Ajay, Shiven, that it is after 24 hours. These 4 statements, one accept question gives you 4 questions beta. Very important potential questions for our FMG exam on 12th January. And you can see here on first day. First day is the delivery day. This is umbilicus here. On first day, means on the day of delivery, fundal height, uterine height is at the level of lower border of umbilicus here. After 24 hours means second day. After 24 hours means it is here. It is 1 centimeter below umbilicus. And 1 centimeter is equal to 1 finger breadth. So the question says on second day, means after 24 hours, how much is the uterine height? 1 finger breadth below umbilicus means 1 centimeter below. So the correct statement. MIST next telegram question. A 33-year-old lady presents with continuous dribbling of urine through vagina. She is unable to go for micturition on her own. I think we discussed this one. This is vesicovaginal. A 32-year-old lady presents with hematuria during menstruation, vesicouterine. We already discussed. Don't be disheartened by what you don't remember. You remember sufficient enough to be happy. We have to get 150 out of 300 beta. Just remember this. हमको कितना चाहिए? 150 out of 300. जो हमें याद है, जो हमारे पास है, उसको और ब्रशअप करना है. मल्टीपल टाइम्स रिवाइज करना है. डोंट फील डिसहार्टन कि यार ये रह गया वो रह गया. लाइफ के लास्ट डे तक बहुत सारे काम अधूरे रह जाएंगे. हमने जो पा लिया, वी शुड फील हैप्पी फॉर दैट एंड वी शुड कीप कंसिस्टेंसी. पढ़ते रहना है, कोशिश करना है, बट द सेम कंटेंट. देखो ना कितना मजा आ रहा है. वी ऑल विल मीट हियर. और कई बार क्या लगता है ना, बहुत सारे स्टूडेंट बोलते हैं सर मन नहीं लग रहा, मन नहीं लग रहा, बिल्कुल पढ़ाई नहीं हो रही, ऐसा लग रहा है कि कभी पढ़ा भी था या नहीं. जब भी ऐसा करे ना तो अपने कमरे में ही, इन योर रूम ओनली, स्टार्ट डांसिंग, जस्ट स्टार्ट मूविंग. आई टोल्ड यू मूवमेंट इज एनर्जी. मैंने तो बड़ा फील किया है. जब भी थोड़ा हिलने लगो ना, मूवमेंट इज एनर्जी. डांस फॉर जस्ट 5 minutes इन योर स्टडी रूम विद योर फेवरेट म्यूजिक, वट एवर यू वॉन्ट. इफ फीलिंग स्ट्रेस, डू सम रैंडम डांस विद म्यूजिक फॉर 2 to 3 minutes. इनको देखो यार, ऐसे बस शुरू हो जाओ अपने आप, अपने रूम के अंदर. 2 minutes 3 minutes ओनली, यू विल बी चार्ज, यू विल बी पम्प्ड अप. अब मजा आ गया है, मजा. इसके बाद फिर आएंगे, विल स्प्लैश सम वाटर ऑन फेस, फिर बैठ जाएंगे. मजा करो यार, मजा कर करके पढ़ाई करेंगे. एक बड़ी इंपॉर्टेंट बात यार, एक्चुअली I made this slide because one student messaged me, sir, MIST has given 19 subjects, लेकिन बाजार में तो एक 20वां सब्जेक्ट भी चल रहा है. There is another subject. लोग कह रहे हैं 20th सब्जेक्ट हो गया क्या? मैंने कहा भाई नाम तो बता दे. कहता है वो एक छोटी कॉपी है, 20th नोटबुक है, एक एक्स्ट्रा नोट्स हम बना लेते हैं. तो मैंने कहा तो तू क्या कर रहा है? बोले सर मैं उसकी जीरोक्स करा रहा हूँ, क्योंकि मेरे मिस्ट में तो वो 20th नोटबुक पढ़ाया नहीं है, तो 20th नोटबुक की जीरोक्स मिल रही है. What is this 20th or additional copy? This is your inner voice. Whatever you forget multiple times when you are solving a question, you are just giving a T&D, you made it wrong. So you mark this in additional notebook. Or the best is to mark it right in your notes only at that particular topic. कोई क्वेश्चन गलत हुआ प्लेसेंटा प्रेविया का, तो बेस्ट है यार ओबीजी की वर्कबुक खोलो, प्लेसेंटा प्रेविया के टॉपिक में उसे वही लिख लो. एडिशनल कॉपी बनाने का भी जरूरत नहीं है. लेकिन अगर आपने बनाया है तो वो एडिशनल नोटबुक सबकी अपनी अंतरात्मा की आवाज है, सबकी अलग है. इसकी जीरोक्स मत कराना. I am requesting with folded hands. चलो, all of the following statements are correct except. फिर पढ़ते हैं. All four are very important for our exam. Deep transverse arrest is mostly seen. Deep transverse arrest is mostly seen in android pelvis. बताओ correct है या नहीं? Is it correct? Just Naresh, you are right. बताओ. DTA is mostly seen in android pelvis. वहां 35 आ जाएंगे बेटा, सच बोल रहा हूं. Which pelvis? DTA. Correct or incorrect? Yes. Direct occipito-posterior position is mostly seen in anthropoid pelvis. Yes. Yes, Harsh? Yes. Management of compound presentation is induction of labor at 37 weeks. Yes, Naushad, Shreya. Yeah. What about Ritik? What about this? C. What do you think about option C? Management of compound presentation means head with hand. Two presentation. Management is Caesarean section. So this is the incorrect statement. Smallest diameter of pelvis is interischial diameter. Fine. So the answer is C. Compound presentation means more than one presentation. More than one. That is compound. And most common is head with hand. So this is the pick from our class notes. Last session. Our Obs-Gynae class notes. Occipito-posterior position with android pelvis. Occipit rotate 1/8 and is stuck here at ischial spine for 1 hour or more despite of complete cervical dilation and good uterine contraction. So this is stuck here. This is deep transverse arrest. Occipito-posterior position with anthropoid pelvis. If occipit is stuck at sacrum for more than 30 minutes, this is deep sacral arrest. And which position is here? Direct occipito-posterior position is more common with anthropoid pelvis. Let us solve. This is our FMG PYQ. This is the most common type of pelvis, gynecoid pelvis. What is the shape of inlet? Round inlet. Platypaloid pelvis. Transverse diameter is much larger. Transverse diameter is much larger than antero-posterior diameter. So this is a platypaloid pelvis. Android pelvis, as you can see, fore pelvis or anterior half of pelvis is much smaller than posterior half. This is why prominent ischial spines are seen in android pelvis. This is why deep transverse arrest is common in android pelvis because of prominent ischial spine. What is the anthropoid pelvis? This is anthropoid pelvis where antero-posterior diameter is much larger. This is why direct occipito-posterior or persistent occipito-posterior is common with anthropoid pelvis and face to pubis delivery may happen. Let us solve this next telegram question. Which ovarian tumor arises from germ cell? Granulosa cell tumor, beta. This is a sex cord tumor. Serous epithelial tumor, they are epithelial tumor. Dysgerminoma, it is a germ cell tumor. Hylas cell tumor is a sex cord tumor. So answer is dysgerminoma. Important question, very important. A patient underwent radiotherapy for carcinoma cervix. Our FMG PYQ 3 session back. Which part will be most radiosensitive? Radiotherapy was given for cancer cervix. And we know gonads are highly radiosensitive. So option given in our FMG exam was ovary. Very good. I know all of you are done through. Someone is waiting to see the word pass, beta. कोई है घर पे जो इंतजार कर रहा है इस पास को देखने की प्रतीक्षा में. And once we pass the exam, see the proud parents, mother and father. Let everyone bring this moment of happiness and smile on our parents' face. Look at the happiness of mother. See. इस खुशी के लिए क्या नहीं कर देंगे हम. पूरा जोर लगा देंगे. 100%. We will put our 100% to get this smile on our mother's face. Look at. See. बच्चा कितना खुश हो रहा है, छोटा सा. See the happiness. And I remember this pyari betiya, Ayusha. She belongs to Odisha, and when she came to MIST, she brought this beautiful portrait of Bhagwan Jagannath ji, Jai Jagannath Bhagwan ji. This pyari betiya, she is Ayusha. I still remember her. She brought this beautiful portrait. God bless her. May you achieve everything in your life. You are loving Viris sir, Kunal sir, Deepa ma'am. How can I revise with more concentration tomorrow? If by chance you feel that I am not able to put 100% concentration, have adequate sleep. बेटा 6 hours सोएंगे यार. सो जाओ. Sleep is a good source of energy. Sit in sunlight also, maybe for 20 or 30 minutes daily. Carry your workbook there and sit in the sunlight. I am not telling you to waste your time. You revise there, but sunlight is also a good source of energy. Be flexible like a child and become better version of yourself with every passing day. My evening is better than my morning. My next hour is better than my this hour. My tomorrow is better than my today. कोई बात नहीं, रात गई बात गई, जो हुआ सो हुआ. अभी टारगेट अचीव नहीं हो पाया, लेकिन मैं अपनी शाम को अपनी सुबह से बेहतर बनाऊंगा. How? I will take some shower, थोड़ा सनलाइट लूंगा, थोड़ा सा म्यूजिक लगा लूंगा, 2-3 minutes I will dance out. Movement is energy, I told you. Just change your mood. थोड़ा सा माइंड को चेंज करते हैं, थोड़ा नहा लेते हैं, थोड़ा सा जो मन करे आए, चाय पी लो, कॉफी पी लो, जूस पी लो, बट एवरीथिंग शुड बी हाइजेनिक. टेक गुड केयर अबाउट हाइजीन. थोड़ा सा I like this, yeah. Dance is very good. 1 minute, 2 minutes. Change yourself. And then sit on the study table. और कोशिश ये करो यार. Try to follow the exam routine, no? 9 to 11:30. बैठ के पढ़ेंगे. 2 to 4:30. We'll sit on a study table and chair with proper attire. You can even wear just shoes, यार. थोड़ा सा acclimatize भी करते हैं अपने आप को exam day के according. If not able to achieve it, don't feel disheartened. Just try again. दिल पे नहीं लेना यार कुछ भी. नहीं हुआ ना? कल बनाऊंगा. कल अच्छे से करूंगा. दिल पे नहीं लूंगा. चलो. See the proud parents. These pics motivate me to teach better. All of the following statements are correct except. Let us read these important lines. I have put the options which are really important for our exam, especially for 12th January 2025. Most important aspect in management of third stage of labor. Fine. मोतियों की माला, बेटा मोतियों की माला भी आ रही है अभी आती है मोतियों की माला. जय जगन्नाथ. यस, मोतियों की माला अभी आ रही है बस. All of the following statements are correct except. Most important aspect in management of third stage of labor is injection uterotonic. Correct statement. And very important statement for our FMG exam on 12th Jan. Early cord clamping is done with neonatal asphyxia. Correct statement. Management of protracted active phase of first stage of labor is immediate cesarean section. What do you think, yaar? Modified Richtgen maneuver is recommended by WHO at crowning. What do you think between C and D? Yeah. Which one? Very good. So the incorrect statement is C. D is correct statement. Let's analyze 4 statements. Most important aspect in management of third stage of labor is injection uterotonic. Drug of choice is oxytocin. 10 international units with intramuscular injection. What is the purpose? The purpose is to contract uterus. When uterus contracts, then only placenta can separate well from uterine wall. This is why most important aspect in management is injection uterotonic, and it has to be given within 1 minute time. Normally, delayed cord clamping is done after 1 minute, within 1 to 3 minutes. That is called delayed cord clamping. Early cord clamping within 1 minute. What are the indications? If neonate has asphyxia, you have to save the life. If neonate has some congenital heart problems, why we will put more load on neonatal heart? Are you getting me? If it is the case of RH incompatibility, to avoid the mixing. And when it is the case of protracted or slow active phase, protracted means slow active phase, we have to rule out CPD and occipito posterior. If it is CPD, only cesarean. If it is occipito-posterior, wait and watch. If nothing, means weak uterine contraction. We do artificial rupture of membrane. Wait for 30 minutes. If required, add oxytocin and reassess after 2 hours. We have clearly written everything in our Obs-Gynae workbook. So I'm sharing it with you. What is the management of third stage of labor? Most important aspect is injection uterotonic. Very, very important. Drug of choice is oxytocin. How much is the dose? 10 international units, intramuscular injection. And it is administered within 1 minute time. Normally, delayed cord clamping is done between how much time? Between 1 to 3 minutes. Fine. What are the indications of early cord clamping? Again, this pic is from last session, MIST Obs-Gynae class notes. Asphyxia, RH incompatibility, if neonate has heart disease. HIV is plus minus according to National AIDS Control Organization. Otherwise not. This is the pic of modified Ritchen maneuver. It is done at the level of crowning. We are doing controlled deflection of fat to prevent the perineal tear. Important image question, our recent FMG PYQ also. Very important image question for our exam. This pic is modified Ritchen maneuver. Let me label because many students are asking for PDF. We will share the PDF in the YouTube description. Modified Ritchen maneuver. This is controlled cord traction. This is NEET PG PYQ. It was asked as the image question. When we are pulling the cord, we are pushing the uterus cephalad, abdominal counter traction. So this is important image question. Modified Brand-Andrews technique. This is controlled cord traction, also called as modified Brand-Andrews technique. Very important image question. Modified Ritchen maneuver. Very important image question. It is done at the stage of crowning. What is the purpose? To prevent perineal tear. What is the purpose of modified Brand-Andrews technique or controlled cord traction? To prevent uterine inversion. Because most common cause of uterine inversion is mismanaged third stage of labor. Now, Miss next telegram questions. Montevideo unit in second stage of labor is. Montevideo unit is uterine contraction intensity into number of uterine contraction. In first stage, it is somewhere around 120 to 150, while in second and third stage, it is somewhere around 300 units, Montevideo units. Mid-pelvis contraction is, if obstetric conjugate is less than 10 centimeter, this is inlet contraction. If interspinous diameter is less than 8 centimeter, this is mid-pelvis contraction. Important statement. If intertuberous diameter is less than 8 centimeter, this is outlet contraction. These three questions are very important for our exam. So mid-pelvis contraction is if interspinous diameter between two ischial spines is less than 8 centimeter. Let me share with you. Just 10 seconds, I will tell you. If these interstitial diameter between two ischial spines, if it is less than 10 centimeter, it is mid-pelvis contraction. Fine. Just a moment. Again, थोड़ा सा पानी पी लूं and you can feel motivated. See the father, see the happiness and proud at father's face. Chalo ji. Next question. All of the following statements are correct except, let me read these important statements. Preferred episiotomy is mediolateral, correct statement. Most commonly used forceps are outlet forceps, correct statement. Vaginal birth after cesarean may be tried with history of classical cesarean section, incorrect statement. Vaginal birth after cesarean is tried only after lower segment cesarean section. We want to prefer just one, maximum 2. Optimum suction pressure in vacuum is 0.8 kg per square centimeter, correct. So this is the answer. Vaginal birth after cesarean, also called trial of a scar, it is tried if there is history of only LSCL, not with upper segment cesarean section. This is mediolateral episiotomy. Why this is preferred? Because if required, incision may be extended. And how much is the angle of episiotomy? Angle of episiotomy is 60 degree. Another important statement for our exam. These are outlet forceps, Wrigley's forceps. This was asked as the image question in our exam just 3 sessions back. Most commonly used forceps are outlet or Wrigley. Preferred episiotomy is mediolateral because there is no risk of injury to anal sphincter and the angle is 60 degree. This is lower segment cesarean section. This incision is called Kerr incision, lower segment cesarean uterine incision. This is upper segment cesarean section, which is also called classical. pH of vagina before puberty is alkaline, 6 to 7.5. In reproductive age group, pH is 4 to 4.5. In pregnancy, pH of vagina is acidic, most acidic, 3.5 to 4. 2.5 nowhere. So answer is 6 to 7.5. Before puberty, during menstruation, in children, after menopause, pH is alkaline, 6 to 7.5. In pregnancy, most acidic, 3.5 to 4. Reproductive age, 4 to 4.5. Important question. Clindamycin may be used to treat. Very important question for our exam. For bacterial vaginosis treatment, we have 2 drugs. Metronidazole 500 milligram BD for 7 days and clindamycin 300 milligram BD for 7 days. So clindamycin and metrozole both may be used for bacterial vaginosis. Important question for our exam. These are the pics of vacuum. This is vacuum. Optimum suction pressure in vacuum is 0.8 kg per square centimeter. When you are in love, nothing is wrong with your life. If you want to pass the exam, fall in love with 19 subject notes. इन सब्जेक्ट से ही बेटा प्यार करना शुरू कर दो एंड सी कितने सारे बच्चे भर भर के पास होते हैं एग्जाम में. ऐसे ही हमको पास होना है, फिर मिठाई खाएंगे. आई नो हर नेम, शी इज डॉक्टर शिवानी, नाइस गर्ल, गॉड ब्लेस दिस पिटिया, यू आर लविंग वेरी सर. A 23-year-old girl presents with complaints of infrequent cycle for last 1 year. So the keyword in the question is infrequent cycle. She has developed mustaches and beard. Which of the following may be associated with this condition? Infrequent cycle means delayed menses. Mustaches and beard means features of hirsutism. So what is this condition? Diagnosis is PCOS. And polycystic ovarian syndrome, testosterone is increased, we know. FSH does not increase in correct statement. It either decrease or normal. LH increase, again incorrect statement. Sheehan syndrome has nothing to do with it. So answer is increased serum testosterone. This is hirsutism. Most common cause of hirsutism is PCOS. This is important image question, necklace sign or string of pearl sign. So diagnosis with this ultrasound image of ovary is PCOS. This is laparoscopic ovarian drilling. Question was asked in our FMG exam 4 session back. Question was laparoscopic ovarian drilling is done to treat. Answer was PCOS. So this is laparoscopic ovarian drilling. PCOS is easily curable. This is PCOS Sara Ali Khan. And this is now Sara Ali Khan. So see the transformation, how the PCOS can be cured. This is the pic from our MIST Obstetric class notes about biochemical changes in PCOS. These increase and they decrease in PCOS. We understood well in our classes. In carcinoma cervix radiotherapy, point B, reference point A. We know there are 2 reference points, point A and point B in brachytherapy. Point A is 2 centimeter above and 2 centimeter lateral, while point B is 2 centimeter above and 5 centimeter lateral to external auth. 2 centimeter above and 2 centimeter lateral, this is point A. 2 centimeter above, no. 5 centimeter above, no. 2 centimeter above and 5 centimeter lateral to external auth. This is our FMG PYQ 5 sessions back. 2.5 years back, this question was asked in our exam. 19 सब्जेक्ट्स की मोतियों की माला बनानी है बिल्कुल इस तरह, एंड हम इन मोतियों की माला को पहन के एग्जाम हॉल में जाएंगे, पूरे 19 सब्जेक्ट्स की मोतियों की माला, एंड देन वी विल वायर आवर न्यूरॉन्स व्हिच आर वायर्ड टुगेदर, दे आर फायर्ड टुगेदर. Don't be just handicapped of 19 subject notes. Try to write the notes here as well in your brain. And it is possible when you are revising with closed eyes as well. We have to enter examination hall with bulletproof jacket. We will not become handicapped of these notes. ये नोट्स हमको असिस्ट करने के लिए हैं, अपाइज बनाने के लिए नहीं. इनके गुलाम मत बनना. ये नोट्स बाहर रखने पड़ेंगे एग्जाम हॉल में जाने से पहले. तो जो नोट्स में पढ़ रहे हो कोशिश करो वो दिमाग में भी लिखने का. Motivation comes from within inside. The feeling that, oh yes, I remember, is the best inner motivation. When you will revise with closed workbook, you will realize, oh, I remember, yaar. That feeling will boost up your self-esteem like anything. इससे बड़ा मोटिवेशन कुछ नहीं मिलेगा. एक फीलिंग आएगी, एक कॉन्फिडेंस बढ़ेगा, यार मुझे याद है. वो फीलिंग तभी आएगी जब हम वर्कबुक को या अपनी आइज को बंद करके रिवाइज करेंगे. Active reading is required for active recall. This is why don't open your phone in between your studies and revision. Do a undivided study for 2 hours. फोन को देखना ही नहीं है. फोन को देखोगे जितना भी पढ़ा सब बेकार हो जाएगा. चलो, next question. A 20-year-old girl presents with retention of urine. She complains of cyclical pain every month. She has not yet started menstruating. Which of the following may be considered next? क्या लगता है बेटा? What comes to your mind? What is the diagnosis of this question? क्या diagnosis लगता है? 20-year-old girl है, complaint कर रही है retention of urine का, cyclical pain हो रहा है हर महीने, उसको आज तक menses start नहीं हुए, primary amenorrhea है, complaint कर रही है primary amenorrhea. आ गई माला, yes भृगु, आ गई माला. क्या लग रहा है? What is the diagnosis? Diagnosis is imperforate hymen. Very good, Ritupriya. The answer is B. Per speculum examination. Because we have to see whether it is a case of imperforate hymen or not. And this is a very important image question for our exam. This is tense bluish bulge of imperforate hymen. Now, who will answer this question? This is the HSG image. What is the diagnosis here? Chocolate question. Who will give the answer? Very important question for our exam. What is the diagnosis in this HSG image? Treatment is cruciate incision. Very good. Yeah. What is the diagnosis with this? Asherman. Very good. Kunika is the first one to answer. This chocolate is for you, Kanika. Wonderful. So this is the Asherman syndrome. This question was asked in our FMG exam. Asherman was not put in option. Our FMG exam had the option uterine synechia. These are all filling defects. This is called multiple irregular filling defect or moth-eaten appearance. Moth-eaten appearance or multiple irregular filling defect. Important question. Potential for our FMG exam on 12th Jan. Let's quickly go through these important questions. How much is the length of pregnant uterus? Let me see. Who will answer? A, B, C or D? Important question for our exam. This chocolate, for the first one, let me see who answers it first. How much is the length of pregnant uterus? Again, few students were clean bold at C, but the answer is D, because it is not 35 to 36 millimeter. It is 35 to 36 centimeter. Length of non-pregnant uterus, nullipara 6 to 7, multipara 7 to 8. Fine. And pregnant uterus 35 to 36 centimeter. What is the narrowest part of uterus? Important question. Narrowest part of uterus is... Let us see who will answer this question. Chocolate for the first one. Who answers it first? What is the narrowest part of uterus? Gokul is the first one to answer. It is isthmus. What is the narrowest part of fallopian tube? What is the narrowest part? Very good, Ritik. Narrowest part of fallopian tube is interstitium. Narrowest part of uterus is isthmus. Important statements for our exam. Few pics to motivate you again. Wonderful. See the proud parents of this bitia. Next question. A 24-year-old girl presents with complaint of restricting pain. So the keyword in the question is restricting pain on movement, mostly in abdomen. She gives history of lower abdominal pain approximately 1 year back. Which of the following ultrasound finding may further add to diagnosis of this condition? So we all know history of lower abdominal pain. Now the fibrous bands developed, which are restricting her movement, so she is feeling pain. So the diagnosis is chronic PID. With these two keywords in the question, history of lower abdominal pain, now restricting pain, the diagnosis is chronic PID. Which ultrasound finding will further add to diagnosis? Ground glass appearance of ovarian cyst, this is seen in endometriosis. Venetian blind appearance of uterus, it is seen in adenomyosis. Cogwheel appearance, yes, this is seen in chronic PID. Necklace sign of ovary, this is seen in polycystic ovarian syndrome. So obviously answer is cogwheel appearance of fallopian tube. And let me show you these ultrasound images. Look here. This is PCOS, necklace sign or string of pearl, but we know it is not included in Rotterdam criteria, but important image question for exam. This is endometriotic cyst. The ultrasound appearance is ground glass appearance with low to medium level homogeneous internally cove. This is cogwheel sign like spokes of a wheel, chronic PID. So we can write this is cogwheel. This is ground glass, means this is endometriosis. This is PCOS, necklace sign. This is Venetian blind, as you can see, fan-shaped shadowing, Venetian blind appearance. And what is this sign called? This is laparoscopy in chronic PID. Let me see who will answer this first. What is this sign called? Laparoscopy chronic PID. Laparoscopy chronic PID. What is this sign? Laparoscopy chronic PID. Important question for our exam. Yeah, I know the question is transferred to you after 20 seconds or 30 seconds. This is why we violin string. Wonderful. Wonderful. So this is violin string sign. Laparoscopy. Now, who will answer this question? MIST telegram group question. Identify the hormone marked by A in given menstrual cycle graph. And I am posting questions on this MIST telegram group daily. And I post at 9 o'clock, 9 p.m. daily. You can solve these questions anytime. And I have taken the questions from various faculties. And all the faculties will be posting, whosoever gets the time, according to their convenience, on this MIST telegram group. This is a closed group. Only MIST faculties are allowed to post in this group. Those faculties who are unable to post, I have taken the questions from them. So I will be posting the questions of their subjects as well. Otherwise, many faculties, they are coming ahead and will post questions themselves. So this question, this Telegram group has the questions posted by faculties only. They are posting important potential questions for our exam. So please answer, what is A? Very good. A is estrogen. A is estrogen. This is estrogen. What is this D? This hormone is maximum after ovulation. So this is progesterone. These two hormones, anterior pituitary hormones, they are maximum on the day of ovulation. So B is LH and C is FSH. This question was asked as the image question in our FMG exam in 2019. And in 2019, examiner marked the arrow on this B. And the question was, identify the hormone marked by the arrow. So we know all A, B, C, D. A, estrogen, D, progesterone, B, LH, C, FSH. Important question for our exam. Since this is A here, answer to this question is estrogen. Pyara bacha, God bless him. See the proud father. See the proud mother. Next question. Let me read the question. A 30-year-old lady presents with progressive, means increasing with passing time, progressive dysmenorrhea and dyspareunia for last 1 year. She is desperate to conceive but is not blessed yet. Means she is infertile as well. All of the following findings sum up the diagnosis of this condition except. We have discussed in our classes very well. If you see the cocktail of these three clinical words, dysmenorrhea, dyspareunia and infertility, answer is endometriosis. Even with two words, dysmenorrhea and dyspareunia cocktail, answer is endometriosis. Let us read the last line. All of the following findings sum up except. So gunshot appearance in laparoscopy, it is seen in endometriosis, correct? In fact, 14th August 24, NEET PG image question. This first line was asked as a image question on 14th August 2024, NEET PG this year. Cobblestone feel on per vaginal examination, nodular feel, correct statement about endometriosis. Ovarian chocolate cyst is seen in laparoscopy, correct. Very, very important statements for our exam. So one except question is giving you 4 questions. And I have included telegram questions also which are important. So I pray Almighty the Great, this session may be highly fruitful for all of you. Halban session on sign on per vaginal examination, it is incorrect. It is painful tender uterus, painful enlargement of uterus. It is seen in adenomyosis. So answer is D. Let us see important image question also for our exam. This is chocolate cyst, seen in endometriosis, seen in laparoscopy. Ultrasound finding in endometriosis is ground glass appearance of ovarian cyst. Laparoscopy finding in endometriosis is chocolate cyst. This is 14th August 2024, NEET PG PYQ. Same image was given and the answer to this question was gunshot or powder burn appearance. It is seen in endometriosis. We all know this is chocolate cyst. Nowadays, there is a fashion of asking these hysterectomied specimen. We all know who will answer this chocolate question. What is this? Very good, very good, very good. Adenomyosis. Wonderful. So this is adenomyosis. Red uterus. There is blood in myometrium. Red, symmetrically enlarged and tender uterus on PV exam, Halban sign, 10 to 12 weeks enlargement may be there. Colposcopy filter color is already our FMG PYQ 5 session back, 2.5 years back. Colposcopy filter color, filter is used to increase, enhance the quality of images. We all know the filter color is green. Which of the following may not be useful in bacterial vaginosis? Who will answer this question? Clindamycin is useful. And this question about clindamycin was asked in our FMG exam just 3 sessions back. And the question was, all of the following may be used except. Same question I have put here. So metronidazole and clindamycin are used. Metronidazole, and that question had tinidazole also in the option. So azole groups, metronidazole and tinidazole, not the fluconazole, and clindamycin. So answer to this question was erythromycin. It is not used to treat bacterial vaginosis. Learn something from candle. Just a small effort counts and shine in darkness. अंधेरे में भी कितनी रोशनी कर देती है एक छोटी सी मोमबत्ती. हमें भी कैंडल से लर्न करना है और थोड़ा सा पढ़ना है. जितना हमने पूरे दिन में अचीव किया, that is enough for that day. Don't feel disheartened. Splash water on your face and use urinal. Sincere advice when you will enter for paper 1 and paper 2. Please don't forget to splash water on your face and use urinal before entering exam hall. And you have to cut blue light, means mobile light, sometime before going to bed daily, so you will have sound sleep with more melatonin. Let us all come out as winner. And finally, these are the winners, as you can see. We'll try to give 100% result. Let every FMG pass the exam. Next question. Let me read it. A 40-year-old lady presents with second-degree uterine prolapse. She is mother of 3 children. She was advised vaginal hysterectomy, but she refused for it. She is a multipara. Second-degree prolapse, we know for first degree only Kegel exercise and ring pessary. For second and third degree, we do the actual management. If she is nullipara, abdominal sling operation, which is also called cervicopexy. If she is multipara, vaginal hysterectomy. Multipara but unwilling for hysterectomy, Fothergill's, which is also called Manchester operation. 60 years age, some comorbidities, Leopold colpoclysis. Absolute contraindication for surgery or pregnancy, puerperium, young girl, unwilling or contraindication for surgery, ring pessary. Management for vault prolapse, 14th August 24, NEET PG PYQ, sacral colpopexy. So this is how we categorize the management of prolapse. She refused for it, so answer is Fothergill operation, which is also called Manchester operation. Cervicopexy is another name of abdominal sling operation. Another name of abdominal sling operation. Leopold colpoclysis is done if the age is somewhere around 60 years with some comorbidity. Ring pessary is done if there is absolute contraindication for surgery. It is done for temporary management of prolapse. Important question for our exam. What is preferred for temporary management of uterine prolapse? Ring pessary. Let us analyze these images. This is normal uterus and you can see the cystocele. In normal anatomy, just an anatomical image, you can see urethra here. But if it is a case of cystocele, means urinary bladder has moved down, it is prolapsing down. So you can see the bladder has come down, you can't see any urethra. So this is cystocele. This is the image of uterocervical prolapse. It was asked in our FMG exam 3 years back, 6 sessions back, and same image was asked on 14th August 24, NEET PG. 14th August 24, NEET PG PYQ, this image was given. What is the diagnosis? So the diagnosis is uterine prolapse. Very important image for our exam. Let me write here, this is uterine prolapse. This is cystocele, already written. This is decubitus ulcer. And what is the management for ulcer? Very important question for our exam, packing. We do packing with acryflavin and glycerin. These are ring pessaries. They are put in vagina. Our FMG PYQ 3 sessions back. Where do we put ring pessary? They are put in vagina. Which of the following is protective factor for endometrial hyperplasia? We know estrogen is the reason for endometrial hyperplasia. So polycystic ovarian syndrome, it is a risk factor. PCOS is a hyperestrogenic condition. Long-term complication may be endometrial hyperplasia. Unopposed estrogen, in fact, the very, very important reason for endometrial hyperplasia. Most common risk factor for endometrial hyperplasia is obesity, and second most common risk factor is unopposed estrogen, because in obesity, more aromatization, more estrogen. PCOS is a hyperestrogenic condition. Oral combined pills, OCP, will inhibit ovulation. OCP is protective for endometrial hyperplasia. It is not a risk factor. Ventouse is contra, another very important question. I have intentionally chosen the questions which are really important for 12th January. Ventouse is contraindicated in all except. So ventouse is contraindicated in prematurity. It can be used in fetal distress. Ventouse is used only in vertex presenting part. So it is not used in face or pro. It is used only in vertex. And optimum suction pressure is 0.8 kg per square centimeter. Now, we have to have plenty of salads and fruits every day. Take some 5 or 6 walnuts daily, 5 or 6 almonds daily. The best is to pour them in a bowl of water and use them next day morning. रात को पानी में भिगो के रख दो. बादाम का छिलका डाइजेस्ट नहीं होता. Soaked with water. They are much helpful. अगर इसको आपको रात में soak कर दिया. If possible, drink 1 white gourd juice daily. It is called सफेद पेठे का juice, if it is possible. You can have some turmeric also. You can add it in milk because weather is changing. You know, थोड़ा सा ठंड भी बढ़ रही है, especially in North India. Some 1 glass, if you are at home, very easily you can tell your mother कि भाई थोड़ा सा दूध लिया, 1 cup. You can add some turmeric, 1 चम्मच जरा हल्दी डाल के. हल्दी, this turmeric is a very good antioxidant. You can have some green tea also. They are also antioxidants. ज़्यादा नहीं पीना. 1 or 2 or 3, they are fine. Next question. Which of the following is most likely complication with the problem shown in this image? Let me see. What is the diagnosis? What is the diagnosis? What is the diagnosis to this question? What is the diagnosis? What is it? Type here. What is the diagnosis? This HSG image, what is the diagnosis? Investigation is HSG. Who will write the problem? HSG, septate uterus. Very good. So the case is septate uterus. Now the question is, which of the following is most likely complication with the problem shown? And most common complication of congenital malformations of uterus is abortion. Because see, the space is reduced to half due to a wall in the midline. So most common complication of congenital malformations of uterus is abortion. So answer is abortion. Let us see who will answer. What is this? You can see even the 2 Leach-Wilkinson cannula. So 2 uterus, 2 Leach-Wilkinson cannula. So it is a case of double uterus or uterine didelphys. This is normal HSG. As you can see, the dye is spilling out. You can see the spill of dye from either side. Normal HSG. Who will answer this question? Very simple. What is this? Very important images for our exam. Yeah, unicornuate. This is a unicornuate uterus. What is this? Who will answer this? What is this condition? Who will answer this? What is this? Bicornuate. This is bicornuate. According to WHO, screening test for cervical cancer is very important question. 10th November INI set PYQ. This question was asked on 10th November in the last session INI set exam. Very simple. WHO screening test for cervical cancer. We have clearly written in our class notes. It is combination of VIA plus HPV DNA. In INI set, VIA was not given. So the next best choice would be HPV DNA. So INI set had the answer HPV DNA. According to WHO, the screening is started at 30 years and then it is stopped at 50 years. So we continue screening from 30 years to 49 years. We stop it at 50. If the lady is HIV positive, we start screening at 25 years of age according to WHO. Management for type 2 endometrial cancer. Type 2 means type 2 endometrial cancer. What is the management then? Grade 2, grade 3, fine. What is the management? We have to do surgery according to the stage as in type 1. But we do chemoradiation in all the stages. So TAH plus BSO, it is done in 1A grade 1-2. 1A grade 1-2. TAH plus BSO 1A grade 1-2. Total abdominal hysterectomy with bilateral salpingo-oophorectomy with pelvic lymph node dissection followed by post-op radiotherapy. No. 1A grade 1-2. TAH plus BSO. Pelvic lymph node dissection is done in 1B if size is less than 2 centimeter. Otherwise, TAH plus BSO with pelvic and para-aortic lymph node dissection followed by post-op radiotherapy in type 2. Type 3 and 4, we do chemoradiation. But in type 2 endometrial cancer, chemoradiation is given in all the stages. This is missing here. Chemoradiation. By chance it was cut. So chemoradiation is given in all the stages. This is laparoscopy of bicornuate uterus. Who will answer this question? Our FMG PYQ. What is this instrument? 5 sessions back this question was asked in our exam. What is this instrument? What is this? Who will answer this question? Very good. Shivendra Yadav is the first one to answer. Please remind me when you come here. Shivendra, this is your Leach Wilkinson cannula chocolate. Leach Wilkinson cannula chocolate. What is this? Who will tell the diagnosis? This is hysteroscopy. Hysteroscopy image. What is the diagnosis for this hysteroscopy? Who will answer this question? Hysteroscopy, what is this wall? What is this wall here? In the middle of uterus. What is this doing here? Very good. Very good, Naresh. Wonderful. Septate uterus. Very important image question for our exam. Hysteroscopy image, septate uterus. So this is a septa in the middle of uterus. Proud moment for this bitia. May God bless her. Next question. Let me read. One X-step question gives you 4 questions. All of the following statements are correct except middle swab becomes wet and blue in methylene blue 3 swab test if it is vesico-vaginal fistula. Correct. Hysteroscopic myomectomy may be done for type 0 and type 1 fibroids. Correct. Most common cause of Asherman syndrome is postpartum curettage. Correct. Best differentiation between Mullerian agenesis and TFS is by karyotyping and not by hysteroscopy. Best clinical differentiation between Mullerian agenesis and TFS, absent axillary and pubic hairs in TFS. Overall best is by karyotyping. Hysteroscopy has no role. Both the conditions, there is no uterus. Now, this is methylene blue 3 swab test. If it is the fistula number 1, means uretrovaginal fistula, topmost swab, she will complain of continuous dribbling of urine through vagina and going for normal micturition also. In methylene blue 3 swab test, swabs will become wet but they will not stain blue. If it is a vesico-vaginal fistula, abnormal connection between bladder and vagina, continuous dribbling of urine through vagina, and septs will become wet and blue. Two septs will be affected, middle and lower one. If it is urethrovaginal fistula, between urethra and vagina, only lowermost sep will be affected and it will turn wet and blue, and she will complain of dribbling of urine through vagina only during micturition. This is FIGO classification of fibroid. We discussed that hysteroscopy may be done in type 0 and type 1 fibroids only. Why? Hysteroscopy means we are removing them by hysteroscope. Type 0 is completely in uterine cavity. Type 1 more than 50% in uterine cavity. Type 2 is less than 50%. So only these two submucous fibroids may be removed by hysteroscopy, type 0 and type 1. So what are submucous fibroids? 0, 1, 2. Then 3 and 4 are intramural fibroids. 3 is touching endometrium. 5, 6, 7, they are subserous fibroids. 5 is more than 50% in myometrium. 6 is less than 50% in myometrium. 7 is completely outside serosa. So 0 and 1, these were the statements in our question. Important telegram questions. Cervical dilatation in active phase of labor in primigravida is. Let me see. Cervical dilatation in active phase of labor in primigravida, it is 1 centimeter per hour. Best ultrasound parameter for assessment of gestational age is crown rump length, CRL. And what is the best time for its assessment? First trimester. Best time for assessment is first trimester. We are just near to the word pass, beta. See the happiness, proud faces. उछल रहे बच्चे, उछल रहे, मजा आ रहा है. हम भी उछलेंगे थोड़े दिन बाद. See the proud faces. They all recently cleared the exam. Last question. Let me read. Which of the following is best management for an infertile couple? So we tried to cover almost all the topics of obsgyne in this session and all the important areas, important questions, including addition of telegram questions here. Which of the following is best management for an infertile couple desperate to conceive with the problem shown in this image? So let us understand what is the problem shown here. Who will answer the name of problem here? What is the problem here? What is the diagnosis? What is the diagnosis? This is bilateral cornual block. And what is the best management for tubal block? This is uterus. What is the best management of tubal block? In vitro fertilization. So the diagnosis is cornual block. Clomiphene citrate followed by IUI. This is the management for unexplained infertility. Intracytoplasmic sperm injection. We directly inject the sperm in cytoplasm of oocyte if there is asthenospermia, severe oligospermia, or azoospermia, post-testicular defect. In vitro fertilization is the answer to this question. Therapeutic donor insemination is done if semen retrieval is not at all, sperm retrieval is not at all possible. Few lines before concluding the session. युद्ध नहीं जिनके जीवन में अभी there are few more telegram questions. Let me quickly go through these. Who will answer this question? This is the important HSG image. What is this HSG and what is the diagnosis? This is tobacco pouch appearance, as you can see here. This is tobacco pouch appearance, and what is the diagnosis here? Tobacco pouch. It is seen in genital TB. Our FMG PYQ as well as NEET PG PYQ, recent ones. Hysterectomy specimens, as you can see, these are all multiple uterine fibroids. Another one, who will answer this question? HSG. We saw HSG image of Asherman syndrome that was multiple irregular filling defects, Moth-Eaton appearance. But what is this filling defect here? This is solitary regular filling defect. So it indicates, what is the diagnosis here? It indicates submucous fibroid. What is the diagnosis? Submucous fibroid. NEET PG PYQ as well as our FMG PYQ. This X-ray was given and the arrow was marked here. What is the diagnosis? Important question for our exam. Very good, very good, very good. This is fibroid. Calcareous degeneration of fibroid. We just saw this image, hysterectomy specimen, red uterus symmetrically enlarged. You all answered well, adenomyosis. What is the diagnosis of this instrument? Important instrument for our FMG exam on 12th January. Who will answer? Who will answer? Very important. This is a chocolate question for all of you. Important question for our exam. Very good, very good. Dronographic is the first one to answer. This is Haywood-Smith ovum forceps. And how we identify ovum forceps? They are spoon-shaped forceps. Haywood-Smith ovum forceps. How do we identify spoon-shaped forceps? They are mostly used for MTP after 12 weeks, second trimester MTP in the combined method for dilatation and evacuation. Already our FMG PYQ, who will answer this question? What is this instrument? Important question for our exam. What is this instrument? Important question for our exam. Chocolate question. And remind me when you come to MIST that you got the chocolate for this question. Curate. This is uterine curate. And I told you when you will come to MIST, please text me 1 week before that you are coming on this date. So text me and you can note down my phone number 7042 109992. 7042 109992. अपना तो जीवन खुली किताब है. Our life is transparent. And text me 1 week before that I am coming on such and such date. This is uterine curettage. Blunt curate is used in obstetrics, except molar pregnancy. Sharp curate is used in gynae to take biopsy क्योंकि वहाँ खुरशना होता है, हमको पता है. Again our FMG PYQ, this ampoule was given in our FMG exam just 4 sessions back, means 2 years back, and the question was, what is this drug? Who will answer? Important question. Our FMG PYQ, what is this drug beta? What is this? The answer is methyl ergometrin. Why methyl ergometrin is kept in brown ampoule? Because it is photosensitive. Let me write. This is methyl ergometrin. Methyl ergometrin is photosensitive. It is photosensitive. This is why it is kept in brown ampoule. Now, most common route of spread of genital tuberculosis is. Most common route of spread of genital TB is hematogenous, while most common route of spread of endometrial TB is direct spread. What is the most common and earliest site of genital TB? Ampulla of fallopian tube. What is the treatment? Anti-tubercular treatment. Which drug is skipped in second half? Our FMG PYQ peak COVID time 2020. Pyrazinamide is skipped in second half of management. Most common symptom of genital TB, infertility. Most common menstrual symptom, hypomenorrhea. Now the new name according to FIGO, light menstrual bleeding or shortened bleeding. Which of the following is ultrasound finding for endometriosis? We discussed. In ultrasound, we see ovarian cyst in endometriosis and the appearance is ground glass. Cobblestone field in endometriosis is PV finding. Chocolate cyst is seen in laparoscopy. Gunshot appearance is also seen in laparoscopy. 14th August 2024, NEET PG image question. Question in waiting on 12th January. How much glucose is used in screening for diabetes in pregnancy in India? How much glucose is used? I hope this is very simple. Important question for our exam. How much glucose is used in screening for diabetes in pregnancy? In India, DIPSI criteria. In India, DIPSI criteria, 75 gram. Ideal time to check for nuchal translucency, our FMG PYQ, 4 session back, again a very important question, potential question for 12th January. Ideal time to check for nuchal translucency by ultrasound is 11 to 13 weeks. And which ultrasound parameter is best to assess gestational age? That was also our FMG PYQ just 3 sessions back, 1.5 years back. And answer was CRL. Best time for assessment of gestational age by ultrasound is first trimester. 18 weeks we do level 2 scan, which is also called anomaly scan or TIFI scan, targeted imaging for fetal anomaly. 22 weeks we do fetal echocardiography. And 32 weeks is the best time to confirm placenta previa, between 32 to 36, earliest at 32. Again, our FMG PYQ, just 2 sessions back, placenta previa is confirmed at what time? Answer given in our FMG exam was 32 weeks. Modified, all these questions are MIST Next Telegram questions. They have already been posted on MIST Next Telegram. Modified retrogen maneuver is done at the time of. It is done at the time of crowning, not engagement, not internal rotation, not external rotation. What is crowning? When fetal scalp is visible at vulva, permanent visualization of scalp hair even when uterine contraction is over. Cisplatin is used in chemoradiation. May be used for cancer cervix as well as cancer endometrium, but if you have to choose between the two, best answer is cervical cancer. Vaginal birth after previous cesarean section, we discussed this, no, we did not discuss this. VBAC, vaginal birth after previous cesarean section. May be tried with placenta previa in ongoing pregnancy, not at all here. The passage is blocked. Placenta previa, the passage is blocked. How can you try vaginal delivery? Macrosomia in previous pregnancy. If it was a previous pregnancy, it has nothing to do with the ongoing pregnancy. So macrosomia in previous pregnancy, you can try it now. Previous classical, not at all. VBAC is tried only with history of lower segment cesarean section. That too, maximum 2, we prefer just 1. History of previous 3 lower segment cesarean section, no. Classical, no. It was in previous pregnancy, nothing to do with the ongoing pregnancy. First step in management of uterine inversion is uterine inversion. The cause is mismanaged, 3rd stage of labor. Uterine prolapse, the cause is mismanaged, 2nd stage of labor. Coming back to inversion now. First step is Johnson's method. Johnson's method means manual reposition of uterus. This is Johnson's method. This is the first step in management of uterine inversion. 3 important questions. Let me revise these 3 important questions. Most common cause of shock after delivery, PPH. Most common cause of shock immediately after delivery, uterine inversion. Most common cause of unexplained shock after delivery, amniotic fluid embolism, which is also called anaphylactoid syndrome of pregnancy. Which of the following is direct cause of maternal death? Our FMG PYQ 4 session back, means 2 years back. Directly related. Preeclampsia. Anemia is indirect cause. Preeclampsia, it is due to pregnancy. So direct cause of maternal death, preeclampsia. Which of the following is not a hyperestrogenic condition? PCOS hyperestrogenic condition, low BMI no, endometriosis high estrogenic condition, fibroid high estrogenic condition, PCOS high estrogenic condition, low BMI, not a hyperestrogenic condition, recent NEET PG PYQ. Quadruple test for screening of aneuploidy is done in which trimester? 2nd trimester. First trimester screening by combined test, SCG and PAPE, and anti-NB scan, nuchal translucency, nasal bone. This quadruple test is very important here. Has been asked multiple times. 10th November 2024, last session ionized had PYQ, and the question was which of the following is not included in quadruple test. And every time they trap with inhibin B. In quadruple test, beta, it is inhibin A, unconjugated estriol, alpha fetoprotein, HCG, and inhibin A. And they trapped with inhibin B. So take care. In quadruple test, it is inhibin A which is the marker, not the inhibin B. Very important MCQ John. A pregnant lady presents at 10 weeks pregnancy with family history of diabetes, our FMG PYQ and NEET PG PYQ, recent one. In FMG, it was asked just 3 sessions back, 1.5 years back. What is the time diabetic screening in present pregnancy should be done at her first antenatal visit? And if the question say, if you missed it, the second is mandatory between 24 to 28 weeks because insulin resistance is maximum between 24 to 28 weeks. Another MIST Next Telegram group question, which of the following is given to pregnant lady to prevent neural tube defects? Folic acid, bachcha janta hai. No rocket science in it. Another important question, how much is the dose of folic acid in a pregnant lady on anti-epileptic uterus? The answer is 4 milligram. This is therapeutic dose. Otherwise, prophylactic dose is 400 microgram. In DIPSI criteria in India, pre-gestational diabetes means overweight diabetes is diagnosed if plasma glucose levels are more than 200 milligram per cent. Between 140 to 200, gestational diabetes. Restitution is 10th November 2024, INI said PYQ. Super duper simple and important question. Restitution is untwisting of neck. Rotation of fetal head. Rotation of fetal head outside by 1/8 due to internal rotation of shoulders, no. That is external rotation. Torsion of fetal, no torsion. Untwisting of neck. That's the correct answer. No question of any torsion. Now, let me go through these few pics and then युद्ध नहीं जिनके जीवन में वो भी बड़े अभागे होंगे, या तो प्रण को तोड़ा होगा या फिर रण से भागे होंगे. हम कहीं नहीं भागेंगे. Be aware or just observe your breathing for few minutes in a day. That will increase your attention span. And I very much like this pic of Surya. And you all know how Surya changed the game. So we are going to change the game in remaining approximately 40 days. बचे हुए 40 दिन में हम अपनी जिंदगी की दिशा और दशा दोनों को बदल के रख देंगे. See the concentration. सिर्फ यही concentration चाहिए. We all need this amount of concentration to pass the exam with flying color. थोड़ा सा और यार, थोड़ा सा जोर और लगा दो. देखो इस बंदे को सलाम करने का दिल करता है. I tried everything. So why don't you try little more यार? थोड़ा सा और ट्राई कर लेते हैं. Give your 100% and just surrender it to Almighty the Great. एक बार अपनी जिंदगी में अर्जुन बनकर देखो. एक बार अर्जुन बनकर देखो और अर्जुन की तरह सिर्फ लड़ते रहो with consistency and perseverance. There is someone to guide you. Almighty the Great. Your parents are here. Your teachers are here. Have faith in your teachers and your parents and just be Arjun in remaining days. चिड़िया की आंख दिखनी चाहिए. Neurons which are wired together, they are fired together. Remaining days में केवल यही करना है. These pics are to motivate you. You can see they cleared the exam. Recently passed students. मजा आता है बच्चों से मिलके. Your lovely Arun sir, your physiology sir, he teaches physiology like anything, you know. देखो कैसे OBG की क्लास चल रही है, इसमें भी थोड़ा तड़का लगा रहे हैं अपना. This is the telegram question discussion in the class. See this प्यारी बिटिया, God bless her. She forced like anything to have sweets. God bless her. May all her dreams come true. God bless this प्यारी बिटिया, sweet daughter. See the parents. See the happiness on their face. All these chocolates are waiting for you as well. God bless this प्यारी बिटिया. Again, happy moments with parents. Just to motivate you. See the mother. See the happiness. See the smile on mother's face. See the happiness and smile on mother's face. If you get less marks in test, another important question yaar. If you get less marks in test, don't feel disheartened. Learn something from Kalam Saab and Amitabh Bachchan ji. I salute both of them. Abdul Kalam Saab, he was rejected for a job in Indian Air Force. इंडियन एयरफोर्स की नौकरी मिली नहीं थी इनको, बाद में मिराज उड़ा लिया इन्होंने, मिसाइल मैन बने. ही बिकेम द फर्स्ट मैन ऑफ द कंट्री, द प्रेसिडेंट ऑफ इंडिया. सलाम कलाम साहब को सलाम. अमिताभ बच्चन जी, first 12 movies, super duper flop. And I still remember, I read in a magazine, मनमोहन देसाई ने अपने घर के 21 चक्कर लगवा दिए थे इस बंदे को, 21,000 रुपए नहीं दिए थे. 21,000 rupees amount was due for a movie. The movie flopped and Manmohan Desai did not give him 21,000 rupees. इस बंदे को देखते ही सलाम करने का दिल करता है. 82 years of age, 82 साल की उम्र है. क्या जज्बा है. और इनको देखते ही मुझे वो लाइन याद आ जाती है, लहरों से डरकर नौका पार नहीं होती और कोशिश करने वालों की कभी हार नहीं होती. लर्न फ्रॉम देम. तो अगर टेस्ट में नंबर कम आए, हम इतनी सी बात से हार मान जाते हैं. इनकी तो 12 पिक्चर फ्लॉप हो गई. इनके पास जिंदगी में कुछ करने को नहीं रहा, पढ़ने के बाद भी जॉब नहीं मिला, हार नहीं मानी, प्रेसिडेंट ऑफ इंडिया बन गए. अच्छों के लिए आने वाली कई जनरेशंस तक ये नाम जिंदा रहने वाला है. बाउंस बैक, कंसिस्टेंसी एंड परसिवियरेंस. आई सैल्यूट बोथ ऑफ देम. और हम कितनी सी बात से हार मान जाते हैं, सर टेस्ट में नंबर कम आए. I was scoring 80%, 70%, 75%, 85%, but in this test I scored 60%. सर इस टेस्ट में केवल 60% रह गया. अरे 60 आ गया, 60 आ गया, बल्ले बल्ले. करना क्या है, भांगड़ा डांस, सेलिब्रेशन. Fine. And this is the QR code of this MIST Next Telegram group, where only MIST faculties are allowed to post the question. Till 11th of January 2025, you will get important potential questions which are really important for our exam on this Telegram group. May everyone enjoy a happy pregnancy, happy and healthy pregnancy. May everyone pass this exam. May everyone be healthy, happy and successful. And our life may be like roses, filled with the roses like this. And with these words, I thank you all of you on behalf of entire MIST team. Beta, this session is really going to be highly fruitful for your exam. All the best for everything. We are connected on MIST Next Telegram. You can join. I saw a lot of messages. So this PDF, because this contains a lot of questions as well, so we'll put this PDF in the description link in this YouTube. And many students are messaging, sir, please post the PDF in MIST WhatsApp group or MIST Telegram group. So beta, I don't think the team would agree for it. In YouTube description, it will definitely be done. Rest depends on team. So all the best for everything. And we are waiting for these chocolates. नहीं पढ़े तो पिटाई लगेगी और पढ़े तो इनाम मिलेगा. Bye bye. Take care.